Dear guests, dear friends, dear LA&HA community, welcome to the second online and 11th LA&HA Symposium on Gynecology and Urology. Again, we have to meet online, even though we were really looking forward to meeting and hosting you in our lovely seaside town of Porto Roșu. The third day of this year's LA&HA Symposium is dedicated to gynecology and urology, and hopefully you will find the program interesting, informative and inspiring. But before we go into details about the program, I would like to invite the president of Fotona, Dr. Matthias Lukács, to share his views on the role that Laser&HA Academy plays in a continuous course of education.
Thank you, Ninja. It is my great pleasure to welcome you to the third day of the 2021 LA&HA Symposium. Unfortunately, this year the symposium is again held online and we will not be meeting in person. However, it may be interesting to remember that Laser&HA Academy started in 2007 as an online website dedicated to educating general population of the benefits of laser medicine. LA&HA has advanced significantly since then, and today LA&HA is a global platform for continuous exchange of information among laser practitioners. This sharing of information takes place either by medical professionals publishing in LA&HA publications, such as the peer-reviewed Journal of Laser&HA Academy, attending meetings and symposiums, such as is taking place today, or by participating in hands-on training courses and webinars. The number of LA&HA certified lecturers is above 100, while there is already over 500 professionals who actively participate by contributing scientific clinical papers for publication at LA&HA. In my opinion, a major advantage of becoming a part of the global LA&HA community is constant education and learning. This does not stop by receiving an initial training at the time of laser purchase, but continues throughout the laser lifetime, allowing practitioners and their clinics to continuously advance and grow. For example, there are several new clinical notes published by LA&HA every month, providing continuous exchange of clinical experiences among practitioners on existing and also new protocols. Further, for those who are more research-oriented, LA&HA also provides a global platform for multi-site clinical studies. I wish you a very pleasant and worthwhile symposium. And do not miss another date. You are cordially invited to attend the LA&HA Super Symposium that is scheduled to take place in person this September in Dallas. Thank you very much for being a part of the global LA&HA community.
Fotona procedures are very safe. The smooth is intrinsically safe. So after the use of Fotona lasers in few patients, I did realize right away that these procedures are very safe, very effective and rewarding, also in terms of from economical point of view.
Look, has laser changed my practice? Absolutely. So that's how I started it off. You know, it was a walk-in, walk-out treatment. It was painless, bloodless, no anesthetic required, no infections, and most importantly, no complications really.
Fotona Laser is definitely my choice because it's established worldwide. And from my experience, I'm a happy user. I'm very excited to have my second unit installed very soon.
I begin to work with a very effective method which give me the opportunity to help my patients without operations have a very good result.
Well, introduction of Fotona lasers completely changed the profile of our practice. So I cannot be more happier that we made the decision 7 or even 8 years ago to start with the gynecology treatment laser treatment of gynecological problems.
After 10 years using other technologies, in particularly CO2 in gynecology, I was looking for something less aggressive because I was completely convinced that being less aggressive, we could achieve even better results. And that was my main concern. to have the possibility to improve my patients' quality of life with a less or a non-aggressive tool. When I found Fotona in a Congress, I definitely didn't think for 1 second. I decided to buy the laser.
A lot of companies wouldn't have the same ethos and dedication to research that an established company like Fotona has. And clearly your long history, was it 40, 50 years in laser technology, stands to you. But that was so important to me to deal with a company that has that reputation. Getting another laser is definitely on the plan.
Well, there are all sorts of lasers now out there. But my rationale was that Fotona lasers are extremely safe. And safety is what we should strive for.
The decision to purchase the Fotona came after I've checked all existing system provided. Now, Fotona was the only one, definitely the most user-friendly, and especially the support. The support was very, very important for me because I need the support. I need to know that somebody is behind me. It's the best thing I've ever purchased, ever.
During today's meeting, we will have a keynote lecture held by Zdenko Vižentin. This will be followed by a session on male health, which will be followed by a session on female health. During the latter, we will talk about urinary incontinence, about the use of Intima Wave, about Gino 4D, surgical and ablative procedures, and of course other emerging applications. The last part of the symposium is a so-called free communication session, where the best abstracts on different topics will be presented by our users.
Ladies and gentlemen, my name is Zdenko Vižentin. I'm working for Fotona on the development of new applications in medicine. Today I will be talking about Fotona technology for gynecology. I will start with this nice chart, which was advised by Dr. Sabina Sencher several years ago. I like it because it is giving you on one place an overview of treatment options, divided by tissues on muscle and connective tissue, and by invasiveness on non-invasive and invasive. Fotona entered the field of gynecology some 20 years ago. You can see on this slide one of our first presentation of ablative surgical erbium YAG. It was done in 2001 in Medica in Germany. And with this surgical mode, we were treating a large spectrum of applications, removing the lesions on cervix, on vagina, anal, perianal, vulvar, urethral lesions. There were also some publications from this period of time. With laser surgery, we are entering this chart in the field of connective tissue treated on invasive way. 10 years later, we open a new chapter of our work in gynecology with the introduction of Fotona Smooth for non-invasive gynecological applications. You can see here the first promotion of our Fotona Smooth treatments for vaginal rejuvenation, 2010, and one of the first lectures about it on the LA&HA Symposium in 2011. When we are talking about these minimally invasive solutions for various gynecological applications, this is really a large range of possible applications. With this technology, we enter the field of non-invasive treatment of connective tissue. And last year, we opened again a new field in technology this time, moving from laser to magnetic stimulation with the star-forming Intima Wave device, which can treat, again, a large range of gynecological indications, all types of incontinence, pelvic muscle rehabilitation after surgeries, and so on. So with the magnetic technology, we enter now the field of non-invasive treatment of muscle. So with Fotona technology, we can cover almost all of these treatment options which are available today in gynecological applications. Looking into all of them on one place, we have 2 laser platforms with which we can do non-surgical laser treatment and also laser surgery. When we are talking about laser surgery, this is variable square pulse erbium YAG and also surgical mode of neodymium YAG. And in a non-surgical, minimally invasive, non-ablative way, the most popular is a smooth erbium YAG, but we also have some applications done in piano and the FRAC3 modes of neodymium YAG. We have 2 platforms, 2 laser platforms for these applications, and one is a very well-known Fotona Smooth or Dynamis, and the newly introduced last year is a Time Walker Intima Laser. For magnetic stimulation, we use a device called Star Former Intima Wave, and the technology is a high-intensity Tesla stimulation. Most popular treatments are with the Fotona Smooth, on which we were working last 10 years. And I will give you just a brief overview of this technology, although I'm sure that all of you already heard of it at least. We are using a short train of micropulses, which are non-ablative and which are doing the heating, controlled heating, very controlled heating of the superficial layers of the tissue up to about 0.5 millimeter, 500 microns, with a mechanism of thermal diffusion. Mechanism of action, how it acts actually to the indications we are treating, it's twofold. We call it dual tissue remodeling mechanism. It is composed of the fast heat shocking and slow thermal injuring. The slow thermal injuring is very well known in medicine for quite some time. We see it as a threefold mechanism of action, like photothermal interaction when we are acting on collagen and producing shrinkage, thermomechanical interaction where the lower laying structures are pulled by shrinking of the surface, and then growth of new collagen fibers by neocollagenesis. There is an additional mechanism here, and this is neoangiogenesis. We are improving the vascularization of the tissue treated. Fast heat shocking of epithelium is a novelty. We discovered it relatively recently, and this is the effect of each particular micropulse in the smooth mode train. This fast shocking is actually activating the keratinocytes, and then keratinocytes communicate with fibroblasts through paracrine signaling, and fibroblasts then start to produce new collagen. This paracrine signaling is a very well-known process, although it's quite complex. You can read more about the mechanism of action in these 2 articles. Both of them are free access, and I would recommend you to take a look into it. When we do our procedures, we use specific tools which we developed in the past time, and this is one of the first pictures showing our first set, so-called G set. We have metallic speculum and some adapters with which we are bringing the laser beam inside the vaginal canal to treat it. Through time, we moved from metallic speculum to the glass one, which is today is the standard one. And later, we also developed a robotic digitally controlled scanning handpiece called the G-Runner, very popular nowadays. And last piece of our tools for the treatment of gynecological application is intraurethral cannula. This is quite unique tool. I believe we are the only one in the world having it, and the smooth mode is the only modality which is gentle enough to be delivered into the urethra. All the tools for smooth technology shown in one place, the manual G-set, the robotic probe, and intraurethral cannula. For the other group of application, which we are doing in surgical way by ablation and cutting, we have different handpieces which can be used for it, but the most popular nowadays is R11 handpiece. Recently, we introduced also micromanipulator for colposcope, through which you have microscopic view, and you can do very precise ablation of lesions. This device is becoming more and more popular. Applications are many. I try to put them in some organized way in this chart, grouped by some common features. two biggest group of applications in which we have been working last 10 years very actively are the pelvic floor dysfunction and genitourinary syndrome of menopause and inside pelvic floor dysfunction, specifically urinary incontinence. We have a procedure called Incontilase, which is very well established on the market. And for GSM, we have a procedure called Renovalase, also very well established. We have a lot of clinical evidence of efficacy and safety for our technology made in past 10 years. More than 70 clinical studies were published in many different, very well recognized gynecological journals. Female urinary incontinence is one of the main indications in which Fotona technology really excels. We published already 36 clinical studies with more than 2,000 patients involved, and the studies were for all types of incontinence, in fact, mostly for SUI, but also for mixed incontinence, ISD, and overactive bladder. Many different tools were used here, objective and subjective, and whatever it was used, results were good, great. In fact, 75 to 90% of patients significantly improved, and the effect was lasting at least 12 months. GSM, we have already 15 studies published with more than 1,600 patients treated. Again, many different objective and subjective tools were used. Significant improvement in large majority of patients was achieved with lasting at least 12 months. And this technology is specifically beneficial for the breast cancer survivors. This technology is also very safe. We proved it already in early days of usage. Already in 2014, we did the first survey, which shows that there are just a few very mild and transient side effects. The next survey we did after 30 articles published, and the picture is the same, very small number of mild and transient side effects. And lastly, last year we published a huge survey on more than 100,000 patients treated in more than 500 clinics in 43 countries all around the world. And again, the results showed huge safety of Fotona Smooth. All observed adverse effects were mild and transient, and the top 4, which are exceeding 1% of incidence, are considered by most of the practitioners not as an adverse effect, but a normal reaction of the tissue to the hyperthermia. So for these two indications, stress urinary incontinence and GSM, we really have a huge evidence about safety and efficacy. This technology is also certified and approved in quite some countries, and you can see already from 2012 on, we are getting approvals for this technology, and more gynecological societies are accepting this technology. This is a picture of the guidelines from 2019 of Italian Menopause Society when they introduced laser therapy in the list of the procedures which can be used for the ladies in menopause. In US, in last time, there are some articles supporting this technology. This is an article in which a group of investigators showed that it is well documented as efficacious and safe. The other article, which is published by the American Urogynecology Society as a clinical consensus statement, also found this technology as efficacious and safe. A Swiss expert group last December published their recommendations for the use of laser in gynecology, and for GSM, they claim that it has evidence level 1B, and they give a recommendation A. For stress incontinence, evidence level 2B with recommendation B. In UK, National Institute for Health and Care Excellence held 2 hearings, one in last year and the second one just in March this year, about stress urinary incontinence and GSM treated by laser. And I'm quite optimistic regarding their decision about introduction of these applications into the normal use. In December last year, on the ICS Congress, Professor Linda Cardozo had a lecture about lasers for GSM, and her conclusions are that there is sufficient and growing robust data on the use of laser for GSM, that the laser is as efficacious as long-lasting current standard treatments, and that today a laser is being offered as a first-line treatment for the patients of GSM. You can see the support of the societies and the top professionals for this technology is growing. Other applications in a pelvic floor dysfunction group, pelvic organ prolapses. Prolaplase, one of our certified application. We did 6 studies with more than 250 patients, and again, results were very good with a lasting of at least 12 months. Another popular application is treatment of vaginal laxity. Our protocol is called Intimalase. And here we have so far 14 clinical studies, also randomized control trial among them, and more than 2,000 patients treated, again with the great results shown with the different tools, objective and subjective. Pain and vulvodynia, we have works in these studies. This is a paper published by Professor Orel, and this is a work done by Professor Alexandra Novako, which was submitted for publication. Interstitial cystitis, bladder pain syndrome is another application for which erbium-YAG smooth showed to be very efficacious. Professor Okui from Japan just published an article about this last year. In the field of chronic infection, we have good results already in vaginal bacterial vaginosis and also in urinary tract infection. I'm sure most of you know about this study of Professor Gaspar on candidiasis with the great results on 12 months follow-up. And in 2019, Professor Zhang from China presented this study in which he was comparing erbium-YAG with the estriol, and his finding is that they are practically equal in the results, and that erbium-YAG is providing an alternative modality for patients who have contraindication for hormone treatments. There are many other gynecological applications, and lichen is one of very interesting. In this field, we have 2 publications, studies showing very good results of this technology for lichen sclerosus and atrophic. Cervical lesion removal, there are many people using this. It's a very elegant way to remove the lesions. Condyloma is practically everyday work for many gynecologists, and this is one of the latest studies published about this. Vulvar lesions, different vulvar lesions. There is a work published last year by Professor Gallardi from Italy, showing again a very nice use of surgical erbium-YAG for this. There is also a range of applications for neodymium-YAG surgery, which can be used either in laparotomy way or in hysteroscopic procedures, like here for myoma or for polyps. Other applications as well. There is a huge field of aesthetic gynecology in which we have many applications covered with our laser technology. Labiaplasty, one of the most popular. We have a specific procedure in which we use a sutureless approach. It's becoming more and more popular. Vulvar whitening is popular, vulvar tightening as well. And we can treat also all sorts of scars on female sensitive areas like cesarean scars, episiotomy scars, and other scars. Vulvar hair removal is also one of the aesthetic applications, which is quite popular, and also quite some people are doing mons pubis lipolysis with the Nd:YAG laser. Aside of this huge range of gynecological treatments, we also can do a lot of other treatments which are not gynecological, falling into the classical aesthetics and some other fields as well. This technology offers very wide portfolio of gynecological procedures, and it's very well clinically proven and supported. We have a specific gynecological web page on which you can find a lot of data. It's a Fotona Smooth web page, and I would recommend you to take a look into it. Thank you for your attention.
The first session of this year's symposium is called Male Health. We will have pleasure to see 3 lectures by Drs. Gaspar, Lu, and Senda. Lectures will be followed by a discussion led by Dr. Kocijancic.
Hello, everybody. I'm going to talk about my experience using the transurethral erbium-YAG laser for the management of chronic pelvic pain syndrome. Well, actually, when we talk about chronic pelvic pain syndrome, our experience using the intraurethral erbium-YAG laser is meant for this type of symptoms is on the treatment of patients with LUTS, so the lower urinary tract symptoms. When we talk about lower urinary tract symptoms, we're talking about perineal pain, is the main symptoms, genital pain, urinary symptoms such as dysuria, frequency, and also sexual dysfunction in its various manifestations. We have done one research, the prostatodynia, the management of prostatodynia in younger patients, which is the ones we have published so far. And we are conducting two other research. One is related to the management of prostatodynia after the transurethral resection for bladder tumor, still doing the follow-up. And the true source sphincter dysynergia, we are also still doing the follow-up. When we talk about prostatodynia after TURBT, we know that the percentage of these operated patients will develop symptoms of LUTS, and although they respond to medication, there is a high percentage of them that will not respond properly to the standard therapeutic measures. So therapeutic measures aim to improve the vascularization of this area, and this is the reason why we decided to start using the erbium-YAG laser. In this particular case, the neck sclerosis and the urethral stenosis post-surgery were ruled out because these two situations, we understand that they need surgical management. So we proposed the erbium-YAG laser as an additional therapeutic tool based on our experience with encouraging results. In the case of the true source sphincter dysynergia, we understand that a contraction of the external sphincter here in the green arrow during the true source contraction results in an incomplete bladder emptying. So there must be a relaxation of the external sphincter during the true source contraction in normal situations. So this is due to a pelvic floor contraction, and the therapeutic measures aim to improve the vascularization of this area, also to produce relaxation of the sphincter. So we also proposed the erbium-YAG laser as an additional therapeutic tool based on our experience with incredibly good results. So in relation to the management of prostatodynia in younger patients with subablative erbium-YAG intraurethral laser, we published this paper last year. And in this research, we focus on young patients suffering from prostatodynia. It comprises a broad spectrum of non-specific symptoms of the lower genitourinary tract, characterized mainly by perineal pain, genital pain, urinary symptoms, and sexual dysfunction. So it's another cause of chronic pelvic pain syndrome, and this pain or discomfort in this region will last at least 3 months with varied urinary and sexual symptoms. There is an inflammation of the prostatic portion of the urethra, and normally this is related to stress, tension, anxiety, and some life habits have led to this symptoms, inflammation of the prostate. It can affect prostatodynia, it can affect males from 20 years of age onwards, and the consultation numbers has risen due to stress and emotional state disorders. This is a new classification of prostatitis and prostatodynia, where you will see acute prostatitis, chronic bacterial, chronic inflammatory and non-inflammatory, and asymptomatic inflammatory prostatitis. The diagnostic is the physical exam. Usually it will not evidence the presence of nothing in particular. The urine analysis, a semen culture may show increase in white blood cells, and a uroculture or a culture of the prostate does not show the presence of bacteria. The treatment in the case of a bacterial prostatitis is very difficult. The goal is to control the symptoms, and because the cure is difficult to achieve. Traditionally, the symptoms of prostatodynia were attempted to be resolved with measures aimed to improve, again, vascularization, oxygenation, and for this reason, combination of kinesiotherapy and tadalafil at the dose of 5 milligrams a day, among others, such as tamsuline, has been used. Tadalafil is a drug that can inhibit the enzyme 5-phosphodiesterase, which is the responsible to deactivating the nitric oxide, which is a vasodilator. So the result will be a vasodilation at the level of the prostatic portion of the urethra. And by improving the vascularization of the prostatic portion of the urethra, the prostatic parenchyma is indirectly improved as well, thus explaining the improvement of voiding symptoms and pelvic perineal pain. But still, the evolution in many cases is towards the chronicity. So prostatodynia remains a complex and difficult problem to be solved. And due to its ambiguous clinical symptoms, to high prevalence, to partially unknown therapeutic strategies, we are facing a very important urological problem. Based on our experience in how we can, the way we can improve trophism in the vaginal area in menopausal women, we based in this experience, and we decided to improve the urethral trophism using the intraurethral laser cannula. We had the experience in 2017 publishing the management of intraurethral type 3 SUI in women using intraurethral laser, and management of urinary symptoms in the genitourinary syndrome of menopause using intraurethral laser, also published, where we demonstrated that we can effectively improve the trophism in the urethra and the bladder neck in women, as we can see in these biopsies. So this is the paper we published last year in Neurology Urodynamics, showing our experience in chronic prostatitis and prostatodynia. So the technique proposed with the subablative intraurethral laser of Erwin Jack allow us to improve local circulatory conditions, firstly promoting a strong effect of vasodilation in the prostatic portion of the urethra and a markedly increase in the oxygenation. We recruited two types of patients, two groups. We wanted to compare in relation to the standard or gold standard option of treatment, which is the tadalafil and kinesiotherapy. And we wanted to see the difference after 2 months of treatment, and we recruited in the same way two types of patients, this type of patients in two different groups. So both groups were evaluated with urine culture after prostatic massage, prostatic ultrasound and uroflowmetry. All urine cultures were negative. Prostatic volume was in all cases less than 50%. And in the uroflowmetry assessment, we obtained in all patients an obstructive uroflowmetry pattern with a Qmax between 10 to 15 milliliters per second. So we did 2 sessions, between 30 to 40 days apart, and then we did the follow-up. These are the parameters we use in our old software, and these are here you see 4 milliliter spot size, 1.5 joules per square centimeter in the new screen, in the new software, 1.4 hertz. In the non-ablative Erwin Jack laser, we delivered 8 shots every 2.5 millimeters, and we did 4 passes. And if you see in this video, we are developing the energy in the session. The session takes no more than between 10 to 12 minutes. So this is our findings finally in our research, where we demonstrated that we can effectively diminish and improve our patients' quality of life in relation to what we call symptoms such as pain, discomfort during intercourse, and also dysuria and frequency. So you can see that it also not only the group treated with tadalafil, but also the group treated with laser, after 2 months follow-up, we have amazing improvements. But what we have seen in the 2 studies we are still conducting is that those type of patients that cannot have good results taking tadalafil, for example, when you combine 3 sessions of laser with tadalafil, you can also improve that percentage of patients that ranges from 10 to 30% that cannot have good effect with standard medication. So in pain and dysuria, the intraurethral laser in men demonstrated that it can have excellent results with good tolerance and no complications. So the Qmax measured by uroflowmetry showed a clear improvement in both groups from 2 to 5 milliliters per second. And Of the 16 patients treated in the laser group, 13 remained with the positive changes after 6 months follow-up. And of the 20 patients treated in the control group, only 2 patients were asymptomatic at 6 months follow-up when they discontinued the medication. So through this pilot study and knowledge of the benefits of a laser tissue interaction, we showed that laser light in the subablative lung pulses of Irving Jack may represent an option in the therapeutic arsenal with that which we have today. It is necessary to perform prospective randomized studies with a larger number of patients and longer follow-up to confirm these initial good findings. Thank you very much.
Hello, everyone. Now we are having discussion after the lectures we heard in a session about male health. And in this discussion panel with Neža and myself, we have Dr. Adrian Gaspar, one of the lecturers, and we have a chair of this session, Professor Erwin Kocijancic from Chicago. And for the beginning, I will ask him just to briefly present himself. Please.
Yeah, hi. Hello, everybody. Thank you, Zdenko, for this introduction. I am Erwin Kocijancic, professor of urology at the University of Illinois and vice chair of the department. And I'm really looking forward to this very interesting and innovative session about laser in lower urinary tract.
Thank you, Erwin. Thank you. And maybe I can just ask you for the beginning, because afterwards you will pose the questions. After seeing this lecture, especially the lecture of Professor Gaspar, what is your, how to say, impression about use of laser in male health?
Yeah, I think it's we're discovering a big Pandora vase. There's a lot of problems that we are facing, and then we don't know, and we don't have the right tools to address them. And we are starting with this, the best and the most difficult treatments for this scenario, which is the chronic non-bacterial prostatitis. It's such a huge problem. Bothers the patients a lot, and we don't have the right tools for them. We don't have a good pharmacological treatment. We are treating them empirically with usually alpha blockers, but the results are like really not there. The patient needs to be on this treatment for months, if not years, and they are very frustrated. And it's frustration is also from the standpoint of treating physician and the patient, because we don't have right tools. So having anything new, and this research, which is published like recently in neurourology and neurodynamics, represents actually a very, very interesting step forward, some new paradigm in treatment of, especially of the chronic prostatitis.
Thank you, Erwin. So I think we can start with real Q&A session, and please, it's your floor now.
Yeah, Adrian, it's a pleasure seeing you, although virtually, again, after these years. Can you explain us a little bit discuss the patient population? Is there anything specifically from this patient population that captured your attention?
Well, when we started thinking about the idea that Fotona Smooth could improve also the quality of life in male patients, we thought about this because after seeing the amazing results that we had in gynecology, treating the urethra for several conditions, such as, for example, recurrent infections, also urinary symptoms. As I work with urologists, I'm a gynecologist, actually, everybody knows, but I work in a big uro clinic in my hometown in Mendoza, in Argentina. And we decided to start treating patients where the gist was to improve the trophism of a certain area. For example, the area of the verum montanum, the prostatic portion of the urethra, because everybody knows that certain conditions, as you have just mentioned, the chronic pelvic pain syndrome or prostatodynia, and also symptoms related to lower urinary tract symptoms due to obstructive problems after surgery, may improve by improving the local vascularization. We have been using pharmaceuticals and kinesiotherapy, and we are strongly convinced after seeing results in different types of patients that by improving the trophism in that area, we can improve symptoms related to obstruction, to symptoms related to frequency, pain, urgency, pain during intercourse, for example. And the majority of our population of patients, for example, in the case of chronic or recurrent or chronic prostatitis or chronic prostatodynia, are mostly younger patients between 22 to 45 years old, for example. But for patients having the trusor sphincter dysenergy, or also prostatodynia after surgery, after the transurethral resection of a tumor, they are in general patients from 47 or 46 to 67 up to 70 years old. And we are conducting now, we have published one paper, actually, the ones I'm going to present during this symposium, but we are conducting 2 more research in different groups of patients, but all of them are basically LUTs, lower urinary tract symptoms.
Yeah. So LUTs, as you know, it's a very generic term. So it's includes everything. So you're mentioning that you guys improve also the flow. Now, how can you? What is your explanation? Why is the flow rate improving in these patients with the laser treatment, where you're not causing any ablation, for instance?
Our hypothesis is because we improve, we have an angiogenic effect. We reverse a condition where when the trophism is improved, then the inflammation of the urethral, the prostatic portion of the urethra improves. In this sense, when you improve the vascularization, the oxygenation, the supply of nutrients and oxygen to the treated area, then you have an anti-inflammatory effect. Basically, we have seen this also with pharmaceuticals, but the problem in certain patients, for example, in patients suffering from prostatodynia, according to the urologists, they have between 10 to 30% of patients that do not have good response to tadalafil or tamsulosin, for example. But when you combine this with the laser, this is our next research, the research we are conducting now. We can effectively have all these recurrent patients, let's say patients where the pharmaceuticals do not exert a good effect. When you combine with a couple of sessions of intraurethral laser, you see that the pharmaceuticals get a good result in the majority of your patients. I mean, the laser won't replace what we have now, pharmaceuticals, kinesiotherapy, but the laser, what the laser have, erbium smooth by stacking shots, promoting a vasodilation and then an angiogenic effect and an inflammatory effect in the end, you will have a better effect of the standard therapies. Mostly for those patients where you don't have good results, because when you have good results with a tadalafil, you will keep on prescribing tadalafil. You don't need a laser. But what happened with those patients? We're talking about the 30% of cases. It's huge amount of them. They cannot get a good result, and we are talking about younger patients from 30 to 40, 45 years old. So I think that there is a huge path to investigate, to do research, but I think that as we have done in women, we can also have the erbium smooth will for sure have in the future a standard indication or specific indication in this type of conditions.
Yeah. So it's just to confirm. So in the study that you published, there were two separate groups. Your side-to-side comparison of tadalafil versus laser, correct?
Yeah.
Yeah. So this is actually you already answered to my next question. So what about a combination? So tadalafil with the laser or alpha blockers, like conventional alpha blockers with the laser treatment, could be like really interesting, because what I noticed is that in the studies is that there's a little bit of a lag response in the laser group. So the better response come later, but this can be actually potentiated with use of some sort of pharmacoinduction to this. No? What is your take on this?
Well, initially, why did we decide to separate and to compare the effect of the erbium smooth in contrast to the standard treatment? Because we were not sure, actually, if we could have an improvement. Because of the anatomical characteristics of the urethra in male, you know, is more difficult to get to the area, although we can do it, but we need water to wash and clean, and the erbium doesn't get well with water, because when you have a moist environment, the energy will be absorbed by the water. So at the beginning, honestly, we were not so sure if this will work. So we decided to recruit some patients and to compare with the standard medication for 2 months, 2 sessions of the laser versus 2 months of medication. Of course, we get good results. And that was what finally we decided to publish this as an experience. But now what we are doing now, what you have said, we need to combine, because if you combine, you will see that for those patients where the alpha blockers doesn't have good effect, you have with a laser a specific indication here.
Right. Now, Adrian, can you just guide us through your technique? Because lasing blindly female urethra, it's an easy task. You have you can do it transvaginal, you can do it transurethral, but in a male it's a little bit more challenging. So how was your technique in these cases?
Well, initially, we the paper we have published, we did it in the past, just positioning the cannula under direct vision with an endoscope, cystoscope, and then we started doing without vision. But now what we are doing, we are doing under direct vision, but we close the water in order not to have water during while you are delivering the energy. I have a video that I will show during my lecture. So we are now shooting the sphincter, which is an area of 1 centimeter, and the bladder neck, which is an area of average 2 centimeters. So sometimes we treat the sphincter, and sometimes we treat the sphincter and the bladder neck, depends on the condition. And we deliver the energy under direct vision. We are doing 8 stacks now of the fluence, and every 2.5 millimeters. So it's pretty easy to do it. It takes us no more than 12 minutes in the operating room. It's under general sedation.
Oh, so you need some sedation. You can do alive.
Yeah,
like
we prefer. Yeah, but it takes you no more, believe me, maximum 15 minutes. And we do in one morning, we can have maybe 10 patients, 15 patients.
Right. And this is, I remember the probe is rigid, so you need a rigid scope to do this. Is it possible, would you advise the friends from Fotona to start developing some flexible zones that probes that you can put into a flexible cystoscope?
I think could be ideal. That should be an option. What I think that we need to confirm these initial findings. We need to confirm, to do longer follow-up, to recruit a larger number of patients. That is what we are doing now, because we want to clarify protocols, to have protocols, indications, parameters. That's what we are trying to find now, which is the best parameter. We don't know yet. We have certain fluencies that we have demonstrated that they work, but are these fluencies the ideal fluencies, or would we have a better effect if we try, as we have done in aesthetics? We are now in doing research in hyperstat techniques, for example, because we have observed better effects, not only histological, but also clinical effect. Well, in male, I think this is the beginning of the story. In the future, maybe we will have flexible tools to work better, but we first need to confirm these initial findings.
Now, going back to the delivery technique, so you decided to go with transurethral approach, no? So do you envision maybe other options? Maybe you can have a better control over the remaining part of the prostate. I don't know if you go transrectally or to the perineum, so that even out of the patient's body, so that you can access this, achieving this better reperfusion, neovascular genesis.
Well, I think after seeing these amazing results, I have talked also to the urologists, because they are the ones who better may suggest me what to do in relation to this. But I think that transrectal could be an option. Transrectal could be an option, a combination, not only to treat this type of problems, but maybe other situations, other conditions. So as far as I'm concerned, there are some doctors who have tried the transrectal erbium smooth with good results. I don't have so far I don't have experience using transrectal approach. We are researching only in transurethral and the energy delivered transurethral. But I think could be a future or possible protocol, the combination.
Now, as a let's go this as a positive side effect of the treatment. We know that a lot of these patients with chronic prostatitis, they do experience dyspareunia, pain with the ejaculation. Now, have you noticed any improvement in their sexual performances? If they had any reduction in the pain, for instance, with this?
Yes, in fact, the majority of the patients of our cases who were now under medication, tadalafil, either tadalafil or tamsulosin, with good results, for example, in urinary symptoms and in genital pain, but they were still suffering from pain during intercourse, during ejaculation, and also still suffering from erectile dysfunction. And after the laser, the combination of these two protocols improved amazingly, mostly the pain during intercourse and the effect in the erectile dysfunction. Because you know that the tadalafil in the majority of your patients will improve erectile dysfunction, but there are certain patients that will not have a good result in relation to that. The combination with the sessions, we have done 3 sessions now. In our initial protocol, we did 2 sessions. Now we increased the parameters, the number of stacks according to our findings, and the number of sessions. We have done between 3, we are doing 3 or between 3 to 4. We do a reinforcement with the session after 3 months. And we have now 6 months follow-up. We are doing now the 6 months of follow-up due to COVID, because during COVID last year was terrible to perform this research. But our findings are really encouraging because of these sexual symptoms.
Thank you very much. I would like to thank Zdenko and Neža to put together this outstanding program. I think that Fotona is envisioning is very, we are used in this Fotona's vision modernity and innovation in medicine. And I would like to thank you, Adrian Gaspar, for this very interesting approach to a difficult problem. And again, for being brave to access this type of a problem as a gynecologist. So thank you again, and hopefully seeing you soon in person.
Thank you so much. It was a real pleasure seeing you all, guys.
Thank you all for joining us, for being with us. This was very interesting discussion. I just wanted to add that there were additional 2 speakers in this session, but unfortunately could not join this discussion. So we send them our questions, and they will reply individually to our questions. So,
okay.
Thank you all.
Okay. Thank you. Thank you, guys.
大家好，今天我讲的这个题目呢，是我们这个耳激光技术啊，是在我们男性前列腺术后啊压力性尿失禁的一个应用的初步的探索，跟大家分享一下。那么我们讲这个男性的这个前列腺术后的这个尿失禁啊，是指就是说这是获得性的尿失禁，就是往往是意愿性的，在做手术后以后导致的这个前列腺的尿控功能的丧失，从而呢发生这个漏尿关闭不紧，产生这个类似于女性压力性尿失禁一样的这样的一个咳嗽啊、走路啊、奔跑啊、漏尿。那么在前阶段啊，我们前2年我们在这个耳激光在女性的压力性尿失禁已经做了很多的这样的病例数了，也获得了较好的临床的数据。那么我也在想，是不是能够通过男性的这样一个也是这个耳激光技术，增加这个男性的尿道的下面的胶原蛋白的增生，可以提供好的关闭压，从而来改善男性尿失禁的这个现象呢？所以说我们从2018年12月份到2020年，我们那个共入组了这个有耳激光，对吧？治疗病人45例。还有对照组37例啊，用生物反馈理疗传统的治疗办法来进行这个治疗，进行一个这个前瞻性的研究啊。2组的患者的平均的年龄、病程还有尿失禁的等一些数据呢，基线显示呢，2组没有统计学差异，都是相类似的。所有的病程呢，都是大于1年以上，经过药物、理疗、针灸等一些常规的一些保守治疗均无效啊，我们给他这个进行入组，而且入组这些病人的尿失禁症状，我们为轻中度或者为中度的这些尿失禁病人。那么这张表。就是我们在这个入组的2组患者的一些基线的一个比较，无论从年龄方面，还有这个手术的时间、尿失禁的轻重度，还有一些程度方面，还有这个各方面尿动力学的一些数据和主观评分表上进行这个对照，2组之间没有统计学差异，就说明可以进行对照的研究。那么，所以我们分为2组啊，我们在这个耳激光治疗组，大家可以看这个图片，我们用这个特殊的在一个可视的目镜下，从尿道这个进入膀胱颈部啊，患者呢是结石位。常规的消毒以后，我们通过这个可视的目镜，把这个激光放到男性患者的颈部，因为男性环尿道有2个弯曲，所以说不能直接插入，必须在这个直视下进入这样的操作。那么操作好以后，再把这个目镜的光学系统退出来，把激光来替代这个目镜系统，把激光放置到位，然后这个从颈部一直到这个男性的尿道括约肌这个部位进行激光来照射，采用的是 smooth 的这个无创模式，用的是209 2G 油的这个手距，能量在3.5焦这个每平方厘米，频率在1.6赫兹，对吧？从颈部一直扫到这个经腹口。我们的这个治疗的方法是这样，每次治疗3遍，这样的治疗3遍。因为男性的尿道比女性的尿道要更粗更宽，所以说我们也想到可能不像女性尿道只做3次就能这样的一个完成。所以说呢，我们一共呢，最后呢，我们是一般性女性是3次，但是我们在这个男性的这个治疗的话，一般性我们用的是6次啊，间隔21天。那么在那个生物反馈这个对照组当中，我们用的是生物反馈常规的物理治疗，采用的是那个法国的33这个 Phoenix 这个进行治疗。患者呢排空后采取仰卧位，刺激电极置于直肠内，接通这个神经电刺激治疗方案，持续治疗15分钟。训练结束后，给予手术后的括约肌无力的电刺激方案，再15分钟啊，一共是治疗这个30分钟。刺激的频率是35到80赫兹。电流强度为患者能耐受到的最大强度，每次治疗30分钟，每周3次，治疗的也是18周啊，前面激光也是18周。那么这些2组病人以后，所有的患者我们分别给他记录这个治疗前、治疗9周、治疗结束的时候和治疗后6个月，进行一系列的评估指标，进行随访观察，以及观察它的疗效和不良反应。那么我们得出的这个治疗以后发现呢，这个耳激光治疗患者治疗6次以后，尿失禁的发生的频率 IEF 和1小时的尿电试验均较治疗前呢有明显的降低，且呢明显优于对照组。那个尿动力学上的腹部的漏尿点压 ALPP 和最大尿道关闭压 MUCP 也获得了这个比治疗前有明显的提升，尿失禁的生活质量问卷表也获得了这个明显的这个提高，患者的全身的情况还有这个明显改善的有效率达到了73.33%，而且呢，就是说患者的这个并发症做下来几乎没有什么并发症，没有出血啊、感染啊、疼痛等都没有。那么我们看几张表格，这张表格就是一个就是患者的一些总的一个他的一个治疗的一个成功率啊、改善率，大家可以看在激光治疗组，它这个明显改善是达到在45例患者当中达到了3例，这个有改善是27例，所以总的有效率是45例当中有30例获得了是有效的改善，达到了66.67%。在对照组用生物反馈当中啊，是1例获得了明显改善，11例是有改善，它的总的有效率是37例当中有12例获得了改善，是只有32.43%。那么这张图呢，也是在治疗当中这个每天的尿失禁次数的一个改善的程度，在随着治疗的时间长，它的改善的这个越明显，对吧？这个绿色的是治疗组，紫色的是对照组。那么在第9周、18周，随着它治疗的延长，它的效果是越来越好。那么结束好以后，我们在第6周以后水保略有上升，尿失禁的这个症状略有复发，但是呢，这也是体现了我们做激光需要在半年以内、1年里边呢要重新做一次的这样的一个理念，对吧？胶原蛋白不是说打了以后就永保，一直会长期存在的，要定期的进行巩固。的确，在6个月以后，有相当一部分病人尿失禁又出现了一些复发。那么这张呢，就是我们一些这个问卷表，对吧？通过这个 ICI 这个 Q 生活质量评选表，对吧？这个来从患者的主观这个评价上来看患者的这个改善程度，那么得出的结果也是相似的。那么这个耳激光的治疗组的效果，从病人的主观改善程度上也是明显要优于对照组的。那么最后我们总结一下，那么通过尿道耳激光来治疗男性前列腺术后，我们一些初步的经验，我们的感受是：第一，它不需要麻醉，局部麻醉都不需要，它门诊就能做，极微创，无疼痛，无出血，这个并发症几乎没有。第二，对于轻中度或者中度的男性尿失禁呢，我们还是获得比较好的一个疗效满意度，但是仍旧需要长期的进一步的数据和大样本的数据的研究。第三，就是我们男性前列腺术后尿失禁的治疗，感觉上就是它的次数要比女性做激光的次数要多，推荐5到6次这样的一个这个疗程。第四，就是由于该技术是微创，对吧？没有并发症，几乎无并发症。那么我们再提出了，是不是一定要等到1年以后才进行治疗？那么前列腺术后如果出现了这个尿失禁症状，在3个月以后，伤口长好以后，是不是早期就可以用来进行预防或者干预来治疗？对吧？这样的话，患者的这个获得生活质量的提高会更好、更方便呢。好，以上就是我们对于这个耳激光技术在男性这个前列腺术后尿失禁一些小小的研究和数据的结果。好，谢谢大家。
日本でED 治療に取り組んでいる千田クリニックの千田元弘と申します。様々な治療をしていますけど、ED に対して、今回そのフォトナのレーザーがどれだけED に効くかも僕も期待しながら取り組んでいるところなので、その治療成績を示していきたいと思います。フォトナレーザーを用いた ED 治療。1999年のバイアグラの発売以降、PD5 阻害剤で十分な結果が得られないケースに新たな方法はないのかと模索をしていました。2010年、低強度衝撃波治療が報告されて、日本においても2012年以降導入が始まりました。2017年、久光先生が56名を対象に結果が、SIM スコアが 64.2% で低強度衝撃波の治療でいい結果が得られたということ。で、施術後6ヶ月、57.1% でEHS が3から4、で、PD5 阻害剤なしで得られた。また、65歳未満の合併症2つ以下の症例においては、SIM、EHS、あと、陰茎周囲腸、優位に改善したという、低強度衝撃波の治療報告をされています。そこで、それ以外ですね、その低強度衝撃波以外にも何か方法ないのかというふうに探っていたところ、フォトナレーザーのレーザー治療に出会いました。これは尿道に使うアプリケーションです。イメージ図ですね。で、うちのクリニックでは15例に対して治療をしました。ED の方の2013年から低強度衝撃波治療を開始して、その後、本人が効果不十分と感じて、さらにレーザー治療を希望された14例。5年前に前立腺全摘を受けた方で、最初からレーザーをやるというふうに希望された方1例、計15例。方法ですけど、その尿道内にエリブミアグの方法と経皮的にレーザーを使うジュームヤグと、この2通りでやってました。ですが、この尿道内と経皮的両方を を成立したのは2例のみです。その他は経費的だけです。間隔と回数は約2週間に1回ずつ、計4回から6回行いました。これが経費的のレーザーの説明ですけども、最初の設定が70になってるんですけども、だんだん換算さなければ120から150まで上げながらやっていきます。で、皮膚の表面温度が40度から41度まで上がったところで、そこからだいたい5分から10分間、この温度が保てるように照射していきました。では、その温度がわかる色なんですけど、黄色からこの緑色ぐらいがいい温度で、赤くなるとちょっと熱いって言われる可能性があります。経費的なレーザー照射の当てる場所ですけど、この陰茎の部分を全周的に当てていって、あとこの陰茎脚全周的に当てていきます。この表面温度がだいたい40度から41度になったところから、さらに5分から10分ぐらい当てました。これが経費的に照射しているところです。全周性に陰茎打っていきます。あとは尿道を照射していくものです。を使用します。こちらが麻酔ですね。まず経費的尿道照射をするときに、尿道内に麻酔クリームを塗布します。15分後、クリームを塗布してから15分経ってから、クリームがあると、レーザーの効きが悪くなるので、もう一回拭き取る作業をして、それからレーザー照射に臨みます。これが尿道照射のパラメータですけど、最初の設定が 1.5になってますけども、麻酔をしてもまだ痛いと、熱いという方がいらして、そういう時は 1.0 まで下げて、で、この4スタックのところを2スタックに減らして、でそれを一番尿道の奥まで入れて、そこから徐々に5ミリずつ引きながら戻してきて、それをもう一度やる。2回やりましたの動画です。尿道のレーザー照射の。まず一番奥まで入れて、4スタックして、だいたい5ミリに行きます。15例のうち3例は、無効でした。1人目は60代ので5年前、前線全摘を受けて、低強度衝撃波の治療はなし、尿道内経石レーザーを治療して、両方併用してやりましたけども、効果なかったです。これは血管性 ED ではないので、適用外だったと思いますけども、次2番は70代、低強度衝撃波治療で効果がなく、糖尿病、高血圧、心筋梗塞、ニトロを内服、PD5 阻害剤の内服ができないため、レーザー照射に期待したけども、効果なかったと。この方も尿道内と経皮的を併用してやりました。3例目は、低強度衝撃波治療で効果なく、フリーテストステロン正常値で、リピドの低下があって、プロスタグランジンの注入テストも問題なく、血管性 ED の可能性低かったんですけども、本人と相談して、レーザー治療もやってみようかということで行いましたが、効果がなかったということで、この方も血管性の ED の可能性が低かったということです。そこで、この3人を抜いた12例で改めて分析をしてみたということです。12例に対して、33歳から75歳、平均 53.0 歳、低強度衝撃波治療を1コース以上施行後、レーザー照射をしてあります。1例のみは尿道内と経皮的照射を併用しています。パラメータですけども、この低強度衝撃波治療を得る前で PD5 阻害剤を飲んでないパターンと飲んでるパターンと、あとはレーザー治療を行う前の IIEF PD5 阻害剤を飲んでないものと飲んでるパターンというので、それぞれパラメータ作って、12名の方はそれぞれ未内服の状態と内服した状態とでのデータを拾っているので、全員がPD5 阻害剤を飲んでいると。グループです。治療後のこの評価っていうのは、施術後の1ヶ月後のデータを拾っています。バルデナフィル、PDF 阻害剤の種類は、バルデナ20ミリ、20ミリです。前例この2種類。低強度衝撃波からレーザー治療までの期間なんですけど、幅があって、低強度衝撃波から数ヶ月からの人もいれば、2年以上経過してからレーザー治療をやっている方もいます。これは IIEF の低強度衝撃波治療の前後変化と、レーザー治療の前後の変化を見ています。衝撃波治療及びレーザー治療はともに IIEF を優位にしています。その効果は、PD5 阻害剤の内服有無には関係しなかった。それだけではそういうふうなことが言えました。これは IIEF の変化率です。低強度衝撃波とレーザー治療での変化の度合いを、見たところ、PD5 阻害剤を飲んでない人、飲んでる人、両方ともにレーザー治療の変化率の方が大きかったということで、レーザーの治療は衝撃波治療よりも IIEF を優位に改善し、 その効果は PDE5 阻害剤の内服の有無には関係しなかったと思います。ベースには、衝撃波治療を先にやってあったというのが、ベースにはあるので、これは、EHS の、これは血液の有意差はなかったんですけども、EHS を、レーザーのレーザー治療と適応変化率、差はなかったですけども、改善されているということが分かりました。PDE5 阻害剤の飲む飲まないに関しても関係なく、治療効果があったということが言えます。まとめですけども、5阻害剤が、いらなくなったという方が30代で2例いらっしゃいました。あと、アンケートを取ったところ、12人のうち11人は、もう一回衝撃波治療をやりたいか、レーザー治療をやりたいかという質問に、レーザー治療をやるというふうに答えています。衝撃波治療にて効果不十分症例に対して IIEF、EHS が上昇しているので、レーザー治療というのは治療意義はあると判断したいと思います。また、初回からレーザー照射の症例も増やしていって、年代だったり合併症の有無など、単純に衝撃波治療との違いを比べていきたいと思います。これは自分の印象なんですけども、陰茎の長さであったり太さにおいては、レーザー治療の方が効果があるというふうに感じたので、またこれも今後分析に取り上げていきたいと思います。あと、している上で重要なことは、やっぱり経皮的にアプローチする上では、低毛が重要で、やっぱ陰茎根部の根元に陰毛があると、そこでレーザーが反応してしまって、41度前後の温度維持に不安定になってしまって、効率が悪くなると、すごく感じますので、低毛が重要かなというふうに感じました。以上です。ありがとうございました。
Hello, everyone. After this nice lecture of Dr. Sanda, we will start a short discussion with some questions. And there are 4 of us in this panel. Together with us is, firstly, I will mention Mrs. Kathy Yoda. She is our partner in Japan, and she will serve here as an interpreter. Then also there are Neja Koron from Fotona and myself. And then, of course, Dr. Motohiro Senda, who was our lecturer. My first question will be about the incidence and prevalence of the erectile dysfunction in Japanese population, which is of course important also for patient selection criteria for laser treatment. So is it very common indication, erectile dysfunction in general and also in Japan population?
有病率はですね、日本人の40代は20% ぐらい。で、50代が 40% ぐらい。60代が約 50% ぐらい。70代が60から 70% ぐらい有病率と言われています。あと、レーザー治療のための患者選択基準は、まだそこまで細かく分析できてないからわからないですけど、血管性 ED の可能性がある方には年齢問わず適用になると考えています。
Thank you. Thank you. My next question will be regarding his personal experience with this laser therapy. He was showing us 2 approaches or 2 steps. One is transdermal with Nd:YAG, and the other is intraurethral with the erbium-YAG smooth. So how he found this, each of these two techniques? What is his opinion about?
尿道内アプローチは、実感として、最初の2例、2人やった最初2人とも痛みがすごくて、あと排尿、おしっこ、施術終わってからの1日ぐらいの排尿時痛がすごく痛いということだったので、ちょっと自分としても、それから次の方々に進めることがちょっとできてなくて、トータル4人までやったんですけど、4人中2人はなんとか完了したんですけど、残りの2人はもう1回やっただけでも次はやめてくれっていうふうに言われちゃったので、その麻酔時間を長くする必要があるんじゃないかなとは思っています。その施術的なそのアプリケーションの使い方に関しても、やっぱり僕は泌尿器科医だから内視鏡 の取り扱いに慣れてるからあれですけど、やっぱり尿道を、ごめんなさい、陰茎をしっかり伸ばして、直線にした状態で挿入していって、で、どこまで挿入したらいいのかっていうのが分かりにくいと思うので、そこら辺がちょっと経験が必要なのかなと思いますけど、慣れてしまえば、1回入れて5ミリずつ引いてくるので、引いてくるだけなんで、それほど難しいことではないとは思うんですけど、ただちょっと痛がってしまうケースが最初に起こっちゃったので、そこからちょっと進められてないっていうところがありまして、ちょっと麻酔方法を考えないといけないのかなと思ってましたけど、その経費的なアプローチだけでも、患者さんの効果が、実感がいいものですから、自分としては、安全で非侵襲的な経費的アプローチを、いかにやっていくかという、期間だったり量だったりっていうのをどういうふうに、提供していこうかなっていうところを考えて、今のところはそういうふうに考えています。で、経費的アプローチはさっき言ったように低毛だけですね。もう本当に簡単なので、やられる方も、楽だと思います。
Thank you. This he already answered to my next question partly because I had in mind to ask him about adverse effect related to treatment. So as I understand, he said that in a NDIAC treatment transdermal, there is practically no side effects. Maybe he can just shortly comment what kind of side effects he saw so far.
全くないです。
Nothing at all.
That's great to hear because this protocol was designed to be minimally invasive, and I'm really glad to hear that also it behaves like this. And my last question for Dr. Senda will be about his view on the positioning of laser treatment among all the other treatments which are available on the market for ED.
いろんなオプションって言っても、どうですかね。そんなバキュームだったり、あと、陰茎直接打つプロスタグランディの注射とかは、やっぱり侵襲性があるので、それはいい選択肢にはならないと思うから、やっぱり、第一選択は PDE5 阻害剤になると思いますけど、飲めない方もいらっしゃいますし、その飲めない方に対しては、あと PDE5 阻害剤飲んでも効果不十分の方においてはですね、やっぱり低強度衝撃波、もしくはこのレーザー治療が今のところは主流というか、なんていうか主流というか、次の作戦になると思うんで、その低強度衝撃波とレーザーとかどっちがいいんだろうかというのはちょっとまだ探っている途中ですけど、経費的に関してはもう本当に安全性が高いし、もう効果が出るっていうのが分かってきてるんで、最初に PDE5 阻害剤が効果ない人に最初にレーザー行ってもいいですし、PDE5 阻害剤飲めない人に最初にレーザー行ってもいいと僕は思ってるんで、今はその低強度衝撃波とレーザーとを説明して、どっちやられますかっていうのを説明してから、チョイスしてもらうようにしてますし、中にはもうハイブリッドでやってる方もいらっしゃいますし、だから、位置づけとしたら血管性 ED に関しては、先ほども言いましたけど、年齢問わず、どんどんファーストでやっていっていいんじゃないかなと思ってますけど。
Thank you for these answers. Thank you all for this discussion, and also Dr. Senda for a very interesting presentation. With this, we will conclude this session, and I hope next year we will have a chance to meet each other in live on the next meeting. Thank you.
Thank you.
これでこのセッションを終わらせていただきたいと思います。どうもありがとうございました。来年はぜひスロベニアでお会いしたいと思います。先生ありがとうございました。
The second session is called Female Health, A first topic during this session will be urinary incontinence. We will have 2 lectures, one given by Dr. O'Reilly and one by Dr. Shu. Discussion will be led by Dr. Phillips.
Good afternoon. It's a great pleasure to give a talk today at the LA&HA meeting 2021. My name is Professor Barry O'Reilly. I'm a consultant obstetrician gynecologist and subspecialist urogynecologist in Cork University Maternity Hospital in Ireland. And I'd like to present today the results of our efficacy and safety of Incontilase in the treatment of stress urinary incontinence, a multi-center prospective sham-controlled randomized control trial. I'd like to thank my co-authors and collaborators in this. I'm the principal investigator of this trial. Well, we've had 3 centres in the UK with Linda Cardoza, Christian Phillips and Philip Toots Hobson. 2 centres in Switzerland, Walter Virek and Annette Kuhn, Stavros Athanasiou from Greece and Adolf Lukanovic in Slovenia. The endpoints of this trial were primarily a reduction in the 1-hour pad weight at 6 months post-treatment in the active group versus the sham-treated group. We looked at secondary outcome measures, including a bladder diary, cough test, the King's Health Questionnaire, the ICIQ, PGI, and PSIQ, and a visual analog score. We also looked at safety in terms of the incidence severity of device-related adverse events. In terms of inclusion and exclusion criteria, you can see from this slide that we recruited women, obviously, of 18 years of age or older, with clinical stress urinary incontinence symptoms and a urodynamic diagnosis of USI. Also those that had no significant improvement in conservative measures, and we had the usual exclusion criteria for a trial of this nature. The tests and measures that we used include medical history, clinical vagina examination, urinalysis, pregnancy test obviously. We did urodynamic testing, which was very important for this type of trial, and also included a post-void residual urine volume. We looked at 1-hour pad weight tests, the cough stress test, a 3-day voiding diary, and the various quality of life questionnaires that you can see outlined in that slide. The procedure was the standard Incontilase procedure from the Fotona smooth technology, which included 2 procedures 1 month apart. In the sham group, we had 37 participants, in the active group 73. The sham handpiece had an exit window that was blocked, so it was single-blinded in that the patient wasn't aware of whether they were being treated actively or not. A power calculation was obviously performed prior to the trial, and we looked at recruiting 120 patients safely to show difference, but we ended up allowing for 10 fallouts or withdrawals. You can see the patient characteristics were fairly evenly matched in both groups from this slide. I won't spend too much there because we have a lot of data to present. Looking at the results, in particular the primary outcome measure of the PAD test, and you can see in the active group that there was a significant drop over 6 months from the pad weight testing. We used the FDA criteria of a greater than 50% reduction showing benefit. And we showed, I think, significantly that there was an improvement in pad testing weights over the 6 months in the active group. In fact, the odds of a successful outcome was 3 times greater in the active arm versus the sham arm. These results were similar after adjustment for key prognostic factors of exclusion of severe cases. The geometric mean in pad weight at 6 months was reduced by 78% in the active arm compared to the sham arm. So again, a significant benefit in terms of the primary outcome measure. In terms of secondary outcome measures, again, looking at this 3-day bladder diary, you can see in the sham and the active arm that there was a significant improvement in bladder diary parameters, and in particular, the median value at 6 months of 0.5 leakages over the 3 days in the active arm compared to 1.16 in the sham arm. This slide is broken down into the cough testing measures, which showed significant benefit in the yellow of less cough tests, less cough tests positive results in the active arm in both the standing and sitting position, but particularly in the standing position in the active arm compared to the placebo. So again, a significant improvement in cough tests. These are the various parameters of the King's Health Questionnaire, and again you can see the sham and active arm, where the slope of the red line in each of those shows significant improvement in King's Health Questionnaire in the active arm versus the sham arm. We broke this down into part 1 and part 2 and the total scores, and you can see that the results as presented in terms of odd ratios, where odd ratio less than 1 implies a greater odds of improved patient outcome, shows again benefit in the active arm versus the sham arm. In terms of the patient global impression of improvement scoring, you can see that in the active arm versus the sham arm, there's a 62% much better or a little better compared to the 21% that you'd probably see in any placebo-controlled trial. In terms of safety measures that we saw in the trial, there were 21 patients that reported concern, 16 in the active arm and 5 in the sham arm. And the reported adverse effects were mostly mild, required no management, and were very transient, and most frequently resolved in within a week or so from treatment. So in conclusion, this is the first multi-center sham-controlled randomized controlled trial of any form of laser therapy for stress urinary incontinence. I think we have shown conclusively that non-ablative erbium-YAG laser therapy significantly improves urodynamic stress incontinence compared to sham treatment. And it is our view, in conclusion, that the non-ablative erbium-YAG laser therapy should be offered as a non-surgical treatment option for patients suffering from stress urinary incontinence. I'd like to thank Fotona for supporting this study and the work from Neja Karan and her colleagues in terms of helping us with the significant logistical issues in putting together a trial of this nature. I'd also like to thank the Statistics Department at University College Cork, who independently reviewed the data and allowed us to present our findings on time for the meeting of LA&HA in 2021. Thank you very much for your attention.
Hello everyone, I'm Dr. Yuan from Tongji Hospital, Huazhong University of Science and Technology, Wuhan, China. It's my honor to speak here. Today I will present some improvements in the anti-SUI procedure with smooth mode erbium-YAG laser. As we all know, smooth mode erbium-YAG laser procedure is a quite novel treatment for the SUI, and it can be divided into 4 steps, which contains incontinence 1, 2, 3, and transurethral treatment. But there are still some controversies during the procedure, which need to be clarified from treatment details and parameter settings. Here we present 3 improvements for the procedure, and I hope these suggestions will be helpful to everyone. First is about the use of local anesthetics. Local anesthetics is required in outpatient treatment, but erbium-YAG laser have the highest energy absorption in water. So when you use local anesthetics, the treatment effect will be compromised due to the energy absorption. How to minimize the energy absorption of anesthetics? Here is our solution. Use clean gauze to wipe off the moisture on the mucosal surface 10 to 15 minutes after the local anesthetic is applied. Or another choice is to switch to intravenous anesthesia. The second, there is a long debate about the therapeutic effects of incontinence 3, which can tighten the vaginal opening. As for the SUI, we know the support of the vagina is very important to women's urinary control. Theoretically, the treatment of the vaginal vestibule does not have the effect of strengthening the vaginal support. We have been discussed with many specialists, from medical colleagues and technical service personnel. As a result, we use incontinence 3 to compensate for the treatment at the distal vagina instead of vestibule irradiation, because the distal vagina is usually receive less energy during the treatment due to the vagina's high sensitivity. We believe that this improvement will be enhance the distal vaginal support and increase the treatment effect. And finally, I think that is the most important. It is the effect of coagulated protein on the lens during the transurethral treatment. We found that there is a lot of mucus on the urethra, especially in male patients. The urethral mucus contains proteins carried from the kidneys to the bladder, and during transurethral procedure, urethral mucus will be heated and the proteins will be solidified on the lens of the handpiece. The shielded lens will greatly reduce the projected energy, thereby greatly decreasing the therapeutic effects. We found this problem with a cystoscope during male treatment, and I think there are also the same problems in the treatment for the female patients. So here is our suggestions. Before each passage, use absolute alcohol to wipe the lens of the handpiece. Another choice is increase energy appropriately, but the parameter settings are varied and still need to be clarified. So these are all the improvements we have made so far. Hope these improvements will help you, and we are glad to discuss more issues with our colleagues. If you have any questions, please contact us. Here is my email address. Thank you.
Welcome to the discussion session on urinary incontinence. I would like to give my word to the chair of this session, Dr. Phillips. Please go ahead. The floor is yours.
Thank you, Neja. I'm Professor Christian Phillips. I'm a gynecologist and urogynecologist based in the UK and a visiting professor at the University of Winchester. I've the great honor of collaborating with one of our speakers today in one of our studies. And I'd like to talk to you first, Professor O'Reilly, regarding your study that you've just presented. Do you think that, obviously the results are very promising, do you think that there are any patients, or in your patient selection, any patients you would definitely advise treatment to, and also conversely, any patient who you would advise not receiving treatment?
No, I mean, I was really delighted to get to the end of this study. As you know, as one of the collaborators, it was a long time getting it done. I think it's a huge challenge anywhere to do a multi-center trial. So we were delighted to get to the end of it. And I suppose there was a sense of trepidation about the results when we handed it on to the external statisticians to review. But again, it was really quite exciting to see the results coming in as they did, showing the huge benefit that this therapy has for women with mild, moderate stress incontinence, and that was the aim of this, and for many years, I think Fotona and all laser companies have been trying to encourage the world to embrace this type of technology for the mild moderate group. I mean, clearly, women with severe stress incontinence, and we actually found that in a subgroup of our study, didn't respond as well as they could have, I suppose. But we would have known that anecdotally beforehand, that in women with severe stress incontinence, they would be more suited anyway to a surgical or a more invasive corrective procedure. But for the significant group of women with mild and moderate stress incontinence, I mean, this has shown, you know, for the first time ever, that it's beneficial. And I think the strength of this study, I mean, if you actually think about what interventions do we have out there for urogynecology, what else has been tested to this level of scrutiny with a randomized control trial in a multi-center environment against a sham or placebo arm? I mean, not even physiotherapy has been tested to that scrutiny. So I think, as far as I'm aware, it's really just drug trials that have been exposed to that level of scrutiny. So really, this trial, I think, will revolutionize, hopefully, how we feel on an international scale with regard to treating women with stress incontinence.
And you say patients with stress incontinence, are you advocating urodynamics in patients before treatment?
I think it's a really good question. It's a difficult one because, you know, in your own country with your NICE guidelines, I mean, the recommendation was that you wouldn't have to do urodynamics before more invasive procedures like surgery for primary stress incontinence. So it's hard for me to stand here or sit here and say that urodynamics should be done before laser treatment. My own personal view is that it should. I think, you know, and the argument I always make when I give talks, and I put up slides showing urodynamics demonstrating cough-provoked detrusor overactivity. Yeah, it mightn't be that common, but, you know, women who have leakage after coughing isn't always as a result of stress incontinence. They could have detrusor overactivity, and I've got some nice slides that demonstrate that. So for me, you know, especially when you're trying to look at patients' expectations, more and more we quite rightly are paying a lot of heed to patient-reported outcome measure tools. We need to be able to go back in cases where it hasn't worked and show patients why it may not have worked, you know, and the only way you can really do that is if you've got a diagnosis beforehand, in my view, of urodynamic stress incontinence. Again, if someone's got mixed incontinence on urodynamics, then again, you can pick apart the management profile needed, whether you try concomitant medication or medication before you do the laser treatment. But really, for me, urodynamics is really important because it allows me the chance to explain carefully to patients what I'm doing and why I'm suggesting this treatment. I don't know how you feel about that.
No, I agree. And I know the NICE guidelines do say you don't need to perform urodynamics before surgical treatment for pure stress incontinence. And I think that's more because of the absence of evidence. But just because you've got the absence of evidence doesn't mean there's an evidence of absence. And you'd be hard pushed to find a urogynecologist in the UK who wouldn't do urodynamics first. So I agree with you completely. Obviously, this is a big study. It's a really important study. It's been a long time in the waiting. Where do you think this leads to now with the introduction of laser? Do you think it will be commonplace yet? Or do you think we need to do more?
Well, you know, I really hope so. I mean, the point of this trial was to include centers in Europe, high-profile centers, centers that are led by high-profile urogynecologists that are well respected in the community. And you know, and so I hope that when this is published, certainly we've put it in for presentation to ICS and also EUGA in December, and I hope both those meetings will be, well, ICS won't be, that's going to be an online meeting, but EUGA will be a great meeting in Ljubljana, the home of Fotona. So it's going to be exciting, I think, hopefully to have a bit of a celebration of the completion of the study there. But go back to your question. Yeah, I think, my hope is that this will get a high impact journal publication. I think it should do. It warrants it for the scrutiny that we use to develop the protocol and the strictness in which it was analyzed. In my view, it's one of the most important studies in stress urinary incontinence management in that it's been tested to the highest, you know, that there are the other trials out there have shown grade A evidence, they say, with slings. But I mean, these are studies comparing, you know, one sling against another, but you know, none of those surgeries that we do every day have ever been scrutinized to the point of being compared to a placebo-controlled arm, which is the true test of benefit in an intervention. So, yeah, my hope is that this will finally get the respect as a treatment that it deserves. You know, there's been a lot of, maybe not negative, but a lot of people sitting on the fence over the years with various editorials in the leading urogynecology journals saying that laser has not been tested or researched properly. So, you know, this for me is a great study, and I'm grateful to Fotona in supporting it, because I think they've shown great corporate governance of a product in that they have, you know, encouraged research into their products before just launching these things onto the global shop front, if you like. So, yeah, I really think it's going to hopefully show the world that here finally is a really good office-based, you know, no complication option for women with mild moderate stress incontinence.
And moving on to those of us who sort of do more laser in our practice, some question I get asked is, what if a patient has got concomitant problems, either GSM and incontinence or prolapse and incontinence? What would you do in those cases? What's your treatment regime or protocols? Or do you have any?
Yeah, look, I mean, I think it's very important to stick to protocols, as you say yourself. I mean, skiing off piste is a dangerous business, and you know, I have to say though myself, and I'm sure you're probably similar, anyone who's been using Fotona laser treatment for a number of years as we have, you do tend to bespoke treatments a little bit for patients. So, for example, I saw a patient today who had you know, some prolapse symptoms as well as stress incontinence. She had a urodynamics that confirmed USI, and examination she had grade 2 rectocele. So what I did for her was an incontinence treatment, but also used the PSO3 90-degree angulated posteriorly to treat her rectocele. So I do that quite frequently, is do a little mix and match of the prolapse lays, if you like, with incontinence. Similarly, I think yourself, you were talking about doing renovalays with incontinence, and I think, yeah, absolutely. But I would be cautious of doing too much on one compartment, as you know. So, you know, if I was doing an incontinence, I wouldn't do an extra pass or a prolapse treatment to the anterior compartment, if you know what I mean. So just be careful that way. Similarly with renovalays, if someone's got GSM, then I think it's probably useful to do GSM treatments first, as you suggested, and then follow that up later on with an incontinence. Is that what you think?
Yeah, I think that's probably our discussions prior to the meeting, as we were saying that. Zdenko, have you got any comments on that at all, or Neja?
Well, I would just like to add that we are finding through the study of other people that in fact this laser can help also to the symptoms of overactive bladder and mixed incontinence. So this is additional field to be studied. In this particular study, it was not touched, but in this moment, as I recall, there is at least 5-6 studies which are done in Asia or elsewhere where people were also observing overactive bladder score and finding a good improvement. I was puzzled about mechanism of action, how it can work, but there was a suggestion by Professor Okui from Japan, and he said that what he sees as a possibility is improved vascularization of bladder. So ischemia of bladder, which can be one of the reasons for overactive bladder syndrome, is improving. And he did even some measurements with ultrasound looking into the dynamic flow of the blood, measuring the change of blood flow and showing that after laser it significantly improves. So this is additional field in female incontinence in which I believe in future we will have also some nice studies.
Yeah, that's an interesting point, Zdenko. I think you're right, but aside from that opinion, the clinical opinion you gave there, I think if we go back to first principles of the development of mid-urethral slings for stress incontinence, the integral theory, Petros would have, if you know, it's quite a complicated theory probably most people have had a look at it anyway, but certainly the initial feelings were that it helped overactive bladder symptoms, suspending the urethra like that. And so that was a thing that was seen with mid-urethral slings, was that there was sometimes an improvement of OAB symptoms. And certainly anecdotally in patients that I have with mixed incontinence, they do seem to do reasonably well. So, but I think it's a very big area that needs to be researched as well, as you said.
And I think the dripping of the funneling, isn't it, of urine into the proximal urethra can then cause a reflex detrusor contraction, and that's why the bulking agents often are quite good with the mixed picture as well. And I think there's some new work looking at microbiome coming out as well, which will be very interesting as well. So thank you very much for your help and your advice and your comments today, Professor O'Reilly. I know you're a busy man, and giving up your time on your birthday as well. We much appreciate it. So happy birthday.
Happy birthday.
Good luck. And good luck with your ongoing endeavors in getting this paper published. Thank you.
Yeah, thanks everyone. Appreciate it.
So Dr. Huan, thank you very much for your talk and your presentation. It's very interesting. I would like to just ask you a few questions, if that's at all possible. First one's regarding the stages of incontinence. You mentioned it's a 4-stage procedure. Do you routinely do the intraurethral step on all patients? Because some of the evidence that came from Adrian Gaspar was that it was initially thought to be targeting patients with intrinsic sphincter deficiency rather than urethral hypermobility. So I'd very much value your comments on that, please. And I'd like to also just ask regarding your use of local anesthesia. Do you use that routinely on all patients? And is that both intravaginal and externally? And you mentioned that if you don't use local anesthesia, that you would try intravenous anesthesia. Have you given any of your patients oral analgesia prior to the outpatient appointment at all? And what proportion of women are actually requiring any form of analgesia or anesthesia? Because certainly in other people's experiences, they may perform the procedure without any anesthesia at all. So I'd welcome your comments. Thank you very much. And you mentioned about the intraurethral phase of the treatment, that due to the buildup of proteins that you change the energy or can change the energy on the laser for your passes. Can you give me a bit more comments on how you quantify that and exactly what energy settings you use? And I'd value also comments from Zdenko and Neja as to their thoughts on that as well. Thank you.
Thank you, everyone. So these are good questions. For the first questions, theoretically, intrinsic sphincter deficiency cases are the best targets for the intraurethral therapy, as you just mentioned. However, we tend to perform transurethral treatment for each patient for the following reasons. First, the EAU guidelines strongly recommended against routine urodynamic testing for most uncomplicated SUI cases because it cannot improve the surgical outcome of SUI. Secondly, according to the results of our animal experiments, urethral treatment result in overlapping urethral mucosa folds and reduced urethral cavity space, which may be one of the mechanisms of the treatment for urinary control. So, the treatment should be effective to both type 3 SUI and other cases. In clinical practice, we will consult with the patient before treatment for each case, and whether urethral treatment is used determines the outcome of the consultation. As for the issue of anesthesia, we have never used oral medications. The anesthesia method adopted is also result in consulting, and depends on the patient wishes. We believe that the tolerance of each local anesthesia case is to the energy setting given by the protocol is quite different. So the energy parameters will be adjusted accordingly. As to the problem of protein buildup in therapy, we have discussed this issue with our Chinese colleagues and Mr. Stanko. My Chinese colleagues sometimes increases the energy to as high as 4.5 kilojoule per square centimeter when treating male patients, which may increase the worry of urinary stricture. The method we use is to wipe the lens with absolute alcohol before each treatment, and the energy setting remains unchanged. I also want to hear Mr. Stanko's explanation on these questions. Thank you.
Well, what I would like to comment is that we saw this increase of energy in intraurethral cannulas by some of our users. And in fact, we have a quite large therapeutic window, which we can afford ourselves to go with energy much higher than initially 1.5 joules per centimeter square. One study, which is just now submitted to be published, in this study, people were using 3 joules, which is double the energy. And Dr. Torresidas from Spain, who was also using endoscope with the irrigation, you know that like this proteins, also the water is taking part of the energy of laser. So as he was using irrigation to wash the urethra, he was applying much higher energies, like 5-6 joules. But of course, half of this energy was spent on the water. So our suggestion is not to do irrigation and to do it on, let's say, naturally moisture urethra. And you have a therapeutic window between 1.5 and 3.5 joules as a safe one in which you can apply the energy. So I believe that investigators who are testing the optimal settings, they actually look into the effects, and if the effects are not as they expected, they increase the energy a little bit.
Thank you, Zenko.
Okay, thank you to all the speakers. Thank you, Christian, for your wonderful moderation of this session. And I'd like to say goodbye to everyone. Bye.
Thank you. Bye.
Bye-bye.
Bye-bye.
A topic on intima wave magnetic therapy will be presented by Dr. Gaviria, and the discussion will be held by Dr. Lukanovic.
Well, thank you so much, Fotona, for inviting me to talk about Fotona Intima Wave, what I call my pelvic gym. And I am categorized in the industry like the laser man, but I feel like I am not the laser man. I feel like I am the electromagnetic guy that likes the electricity and magnetic waves and how they travel and how they deliver energy. And that's why I work with ABDs, energy-based devices. And of course, I have been in the use of different devices of lasers, like the Irving jack, ND jacks, CO2s, diodes, hybrid. You know that my favorite is to use the smooth mode on vaginal canal. Eventually, I think that we will use some other wavelengths like the use of the ND jack on the 3D, but there are some other electromagnetic waves like the LADs, light emitting diodes, radio frequency, and the use of ultrasound on the pelvic floor. Today, I'm going to talk about the magnetic fields, the heat, the stimulation that this electromagnetic wave does in the pelvic floor. And the intima wave is just a strengthening of the pelvic floor muscles to treat urinary incontinence. So this heat is high intensity magnetic stimulation. It is really a non-invasive, painless method that allows for non-contact stimulation for both superficial and deep tissue and the muscles to strengthen and be over pulsated with this with the influence of this high intensity magnetic field. This is because of Tesla. I'm going to put this little video of introduction of heat and And that is the presentation of Intima Wave. I am so happy that I can get involved with tissue remodeling in the pelvic floor, but also now I can help with the strengthening on the support of the muscles. And this was the first study that I saw that the systometric capacity improved by the use of this technology. And this was, I don't know, like maybe like 5 years ago that I got encountered with this. And I know that my professor Lukanovic was the one that started this, and that's why I fall in love with this share that is developed in Slovenia and is called now a Starformer with the Intima Wave. What I did with that is create a protocol on different sessions on to use it on the vaginal relaxation syndrome, stress urinary incontinence, mixed urinary incontinence, urge, genitourinary syndrome of menopause, and pelvic chronic pain. Those are only females. I haven't tried it on the males. So what I did is I got 2 sessions every week for 3 weeks. So six treatments in total. And I did assessment on VASA scale, ICQCF, and the quality of life impact before, right after 1 month, and the follow-up at 6 months. So this is the pelvic gym on all the applications for vaginal relaxation syndrome and incontinences. And let's talk about each one of those and how they change within the time. For example, the vaginal relaxation syndrome, that the patients, they feel what is the improvement on that, how excellent they were from before to the final treatment, and how that is going down within the time. That's why I think that going to the gym one single time is not going to make you very much muscle, but you need to repeat this, and you have to do some maintenance to maintain that muscle tone. This is vaginal relaxation syndrome. In terms of ICQCF, we see that the changes that they have was the score lowered down even more to 6 months. So they strengthened it. Again, this is 6 treatments, and those treatments were 3 weeks between my treatment of incontinence. So I was doing the incontinence 3 times, and in the middle of the first session, between the first and second session, I did my pelvic gym. So you can see with tissue and strengthening on the pelvic floor how the score went down. If we don't do maintenance, you can see that almost they return to the final stage when they come at 24 months follow-up. The same thing happened here with the mixed urinary incontinence. So we know that works for stress urinary incontinence, but here is with the mix, and here you can see how good also is the modulation. Remember that this is an electromagnetic field that is also helping with the receptors in an overacting bladder. So that's why we go like from a 9 to a 2 in a 6-month period, and then it goes back up. So maintenance, I think that is the key point to your pelvic gym. So it's not only doing the 6 treatments, it's doing maintenance. In genital urinary syndrome of menopause, we have some improvement, but remember that it's more like the tissue that needs to be repaired. So we have some improvement on the quality of life of this patient, but the pelvic strengthening is more based on the vasodilatation that this electromagnetic field can have. I feel like pelvic chronic pain didn't work very much on this patient because for that time that I did this, we didn't have the correct protocol in terms of frequency that now the company has developed. My conclusions is that the HIIT is a safe procedure and has a possibility for being used in all types of incontinence. Urge incontinence is one of the best options that I can see that I didn't have with the laser before the previous studies of overacting bladder, and it can modulate less oral treatments when you have mixed incontinence. Helps muscles in vaginal relaxation syndrome and the stress urinary incontinence, have some changes in vascular GSM, and the combination with lasers can be the best option for the patient. Like I say, I think I need to organize my protocol for lumbar pelvic chronic pain. So urge urinary has to be more objectively, for future studies, has to be more objectively quantified that with the quality of life that I did. So that is, I think that this should be improved. And the GSM also, we need to see different symptoms, more than quality of life and improvement. I think that this has to be something that maybe my Professor Gambachani of Lukanovic should look into this. So I believe that if we put these patients into postpartum, to sit in the pelvic gym is going to be a therapeutic way to not to get vaginal relaxation syndrome or incontinence or prolapses. So this is like a really nice therapeutical approach for this patient. These are my contact information in case that you have any question. Thank you so much for this time that you give me.
Thank you, Dr. Gaviria, for this beautiful presentation. I would like to now invite our chair of the session, Professor Lukanovic, to share his views or to make a comment, to ask a question. Professor Lukanovic, please go ahead.
Thank you for the possibility to share the experiences. I'm very glad that you started with this therapy. It was before we have used Fotona laser that we have started to use magnetic stimulation for urgency urinary incontinence. And when you started with Fotona, I very soon realized that this is the combination of the therapy, because You must know that diagnosing urinary incontinence may be quite complicated. We know urodynamic stress urinary incontinence or clinically assessed stress incontinence, like Wayne theory has. So most of the patients have mixed symptoms.
Yep.
We have to exclude inflammation. That's number one. Then we have to start conservative treatment. This is, we say, sine qua non. Always we have to start conservatively. It is user-friendly therapy. And beside diet, exercises, we can use some electric stimulation, and this is improved electric stimulation because you need not to introduce any probe into the vagina or rectum. So we have very good results. The only problem is to assess this therapy because it's quite time consuming. You need several sessions. I'm not sure if until now 6 sessions is enough. When you exclude inflammation, you start with magnetic stimulation. I think before you start the laser therapy, you start magnetic stimulation because you can treat urgency, frequency, pain, and also, as you said, strengthening of the muscles. But you need more sessions. So I'm very glad you started to use this. We need more and more talking and meetings to persuade people that this is a therapy of value. I'm convinced.
I have to agree with you because I followed you. I think I got into this magnetic therapy because of your work. I think that is the winning combination from tissue and magnetic therapy. This is a winning combination for any pathology on pelvic floor, male or female.
And there are very few contraindications.
Yeah. Isn't that?
We started a research with male incontinence after radical prostatectomy. And clinically, we have very good results until now. And we are preparing ourselves to publish this data.
Well, I will love to see that because I think that what you say is that we need to increase this clinical knowledge with scientific proof. But we know that this works, and I hope that this gets to our Fotona users to start thinking about the synergy that the light and the magnetic field will have on your patient. And I encourage everyone to get into this technology. I am so happy that Fotona gets the star former, and I hope that it gets here to the US soon, so I can enjoy of this therapy here in the States. I have to agree also that you appointed that we should start with magnetic therapy before thinking about laser, and that we need to set a perfect number of sessions. What I did, this is me in Barcelona when we had with Luciano Vascoy, where we had the magnetic chair. What we were doing, and this is just a suggestion for my peers that get the star former, what we were doing, we were charging a monthly fee, and patient can come and sit on the chair twice a week. So, this is like a gym. They can come and they can sit on the chair, and they buy like a loyalty club. So 6 sessions might not be good enough, but that's what I did for for between my laser treatments that I was doing this scientific study, or this trial that I just got me started. So I feel like there's so much to be done and to execute for the perfect protocol, Professor Lukanovic.
Thank you. It was really a nice presentation and great discussion. As you already mentioned a few times, I will just confirm your thoughts. Fotona also decided to enter this technology because we noticed the advantages, and we are looking forward for some studies which will scientifically confirm what you already told us. I know that Professor Lukanovic did one study in past and see what Jorge is doing now. But of course, we need more studies, and especially we are looking to do studies in combination therapy of laser and magnet, because we see the role of magnet in strengthening of muscles and the role of lasers in improving of connective tissue. So both are winning combination, definitely.
So, well, thank you so much for having me, Dr. Lukanovic. It's always a pleasure to see you. And
To meet you.
Bye-bye to my family, Fotona family.
Thank you.
Thank you.
A hot topic on Gyno4D will be presented by Dr. Gambacciani, who will after the lecture discuss the issue with Dr. Gaviria.
Hello everybody. First of all, I'd like to thank Fotona for the invitation. Today, I'd like to present some data obtained with the new treatment protocol, the Gyno4D, a new option for gynecologists to treat vulvovaginal atrophy and particularly the superficial dyspareunia. We know that the symptoms of genital syndrome menopause can have a negative effect on quality of life. And today, after 9 years of experience, publications, extensive preclinical studies, more than 70 papers published in peer-reviewed journals, we know that the vaginal laser is an evidence-based option for the treatment of GSM. Particularly the Renovalase, the classical, let's say, two-step protocol, is very effective in postmenopausal women suffering from atrophic vulvovaginal atrophy. You see here the data we will be collecting in our department. You see after L1, laser 1, laser 2, laser 3, a rapid decrease of the symptoms of dryness and dyspareunia with an improvement in the vaginal health score. And we performed long-term studies showing that the effects of laser last at least 1 year, while the local treatment, when you stop the local treatment, the dryness and dyspareunia go back, while the effects of a vaginal erbium laser last at least 12 months. And you see here the 84% of postmenopausal women treated with laser were very good responders, and they were asking to repeat another treatment after at average 12 months. And but there are some women that are not so happy. Those women that are suffering particularly from superficial dyspareunia, for the atrophic condition of the posterior commissure, with an increased sexual dysfunction, feelings of isolation for both partners, with issues related to the self-esteem and body image of the woman, leading to even depression and anxiety. Also because in some women, the posterior commissure atrophy is associated with the postpartum scars, with the effects of long-term chronic infection, or even the presence of lichen sclerosis. And today, we have a new opportunity, the Gyno4D, a new approach with the erbium smooth laser, mainly with the hyperstack that Adrian Gaspar was exploring in this month, and the neodymium. Basically, what we are doing with the Gyno 4D is similar to the non-invasive facelifting of the Fotona 4D. We are combining both wavelengths, erbium and neodymium, enabling the clinician for a large number of various applications, not only the GSM or stress urinary incontinence and prolapse, but also lichen, episiotomy, caesarean section scars, the condyloma, and so on and so forth. Also using the deeper neocollagenesis pain relief induced by the neodymium. So the Gyno 4D is a complete vulvovaginal treatment with using the Renova laser smooth, diffract-free and piano from neodymium, and the fractional resurfacing from erbium. And basically, is an all-inclusive treatment. And with Adrian Gaspar and Jorge Gaviria, we are going to publish in the next few months a new book, The Essential for Gynecological 4D, the cookbook for functional and aesthetic gynecology. But today I'd like to show you the first data we collected in women suffering from superficial dyspareunia. As you can see, women treated with the Renova laser, they see a decrease in the superficial dyspareunia, and this decrease is statistically significant. But when you use not only the classical Renova laser, but you use the erbium with the hyperstack, 9-stack, 3, 4, 5 passes, and the very low fluence associated with the treatment with the neodymium YAG piano, with the very low fluence and 6-12 passes, you see that the effects on superficial dyspareunia are even better. And you see the difference in comparison with the classical Renova laser treatment. And please, dear colleagues, take into consideration that these two groups of women were similar. Both they were, the age was about 60, with a 12, 11 years from menopause. So basically, they are very similar groups. And therefore, we can say that today, the Gyno 4D is a new non-invasive option to restore functional aesthetic vulvovaginal condition with a combination of protocols with the two synergistic wavelengths, with single protocols that are fixed and validated by the clinicians, but the combination in the procedure are flexible according to patients' needs. So the Gyno 4D remains an office walk-in without procedure with a treatment that lasts 20-30 minutes. But definitely this Gyno 4D has been demonstrated to have a high success rate, resulting in restored not only vaginal function, but also vulvar function with a little or no downtime at all. And this is, I think, a new challenge for the Vela. The Vela family is the biggest gynecological laser community in the world, and they are going to provide the solid evidence collecting information in a very large database, as we did for Renova laser and Inconti laser in the last years. And with that, I'd like to thank you very much for your attention, hoping to see you soon in person as soon as possible. Thank you very much. Grazie.
Hello, everyone. Welcome to the discussion session of the Gyno 4D topic. Unfortunately, our chair, Jorge Gaviria, could not be here with us. He was delayed somewhere else. So Zdenko will take his place and he will post his questions to our speaker, Dr. Marco Gambacciani. Zdenko, please go ahead.
Hello everyone. I'm glad that we have Marco with us, who is really our very good user and long years with a lot of experience practitioner, and also author of many articles. And he came out with a new concept of his work, where he is combining more applications with two wavelengths than he was working before, only with a smooth erbium YAG. So he will be presenting today, he presented today his work with the 4D, and in next 10-15 minutes, we will have some discussion about this new approach.
My whole idea was just to mimic the effect of Fotona 4D for the face, for the vulva and vagina area, because many women, they do have many problems, not only, for example, vaginal relaxation or vaginal atrophy, but a lot of women, they have also pain for scars, for episiotomy scars. They do have the long-lasting effect of chronic infections that they per se induce some atrophic changes of the vaginal mucosa, and the introitus is often atrophic also in young women suffering from chronic candidiasis, for example. And the whole idea is to use the best we have to improve the vaginal and vulvar conditions. And I'm implying in this the use of smooth for the erbium and mainly for the mucosa, and the piano, the neodymium YAG piano mode for the vulva. And I had in the last few months very good results in terms of resolution of pain induced by the presence of episiotomy scars, the resolution of the pain induced by the atrophy of the perineum induced by the chronic candidiasis, and the atrophy of the commissure induced by, for example, cases of aromatase inhibitors, radiotherapy for cases of colon cancer that were irradiated, and with the piano, the effects on the vulva and in the outer part of the vagina are even more evident than with the smooth alone, with the erbium alone. I'm not saying that the erbium per se is not effective. I won't say that because it's not true. We published, as Zdenko said, many papers demonstrating that the smooth mode is very effective in reducing the atrophy. But when you are going to be around the clitoris and around the posterior commissura, you need to change your parameters. First, with the smooth mode at the very low fluence. And in the posterior commissura, very low fluence of erbium plus piano. And this concept of very low fluence of erbium with a smooth mode was called by Adrian Gaspar the hyperstack. And it was a genius, because when Adrian told me that he was treating the women with a problem with the sexual drive, with the smooth mode, with the hyperstack around the clitoris, we set down a protocol also for the atrophy of the introitus and the atrophy of the posterior commissure. And it was working just great. At that moment, I said, the outside is the skin. And with the skin, the piano is working perfectly. And I use also the piano. And in my presentation, I clearly demonstrated that using both the Renovalaise hyperstack with the erbium plus a piano mode with very low fluence, the effects on superficial dyspareunia, I mean, the pain that the women, they have when they do have the initial sex at the opening, almost disappear in 2-3 sessions. That's why I think that the concept of a gyno 4D is a step forward in order to improve the quality of life of our postmenopausal women, but not only postmenopausal women, all the women that do have problems with the pain, the perineal pain. And by the way, the Fotona gave us now the new probes, the Marco probes for pain. It's not after me, there's after other guys, okay? But the Marco probes are very helpful, can be very helpful to treat the pain in the vestibulum and the perineum. And we hope to have some new data in the next few months using these new probes. But for the meantime, at the meantime, we are using our R33 with a piano, with a very low fluence, 40-50 joules, 6 up to 12 passages, just brushing, and the effects on episiotomy scars, on the atrophy of the posterior commissura are just fantastic, just fantastic. Also, using the smooth mode for all the vagina, and the smooth mode with a hyperstack at a low fluence 1.75 joules on the clitoris part. And that's why the concept of gyno 4D, so using both wavelengths with a different settings, with the different modes, in order to answer to the needs and the questions that the women are asking us.
Great, thank you, Marco, for this insight. What we are doing with this concept. I have just one question, which is partly related to it. Namely, vulvodynia is a very large indication. And what you were telling us about your superficial dyspareunia and all of this issue, I'm not an expert, but I see this as a subset of vulvodynia. Is it true?
Yeah, is a part of the big chapter of vulvodynia. And vulvodynia is a nightmare for the gynecologist. But at least we can have the possibility to treat the symptom, the pain. Maybe with the laser, definitely we cannot cure the etiology, why women, they do have the vulvodynia. But if we can help our women in reducing the pain, improving the tissue texture with our thermal therapy, it's enough, you know. Also, with the Renovalaise, we do improve the vaginal condition without giving estrogens, but nevertheless, we do improve the quality of life of our women. So for the vulvodynia, we may improve the quality of life of our women with a thermotherapy, maybe we don't remove the cause of the vulvodynia, but we can remove the pain, and for the women is enough.
Yeah, I agree with you. Great, great. Now knowing you and knowing Vela activities, I can expect that in fact you will bring this new application also to the broader number of your colleagues, and I hope we can expect a study in which we will have from multiple centers also results about, for the beginning, about superficial dyspareunia, and then also for something else. So is it in a pipeline?
Yeah, also always a thank to your support and the Fotona support, because I must acknowledge the support of Fotona in our studies and in our following our ideas in doing some work. For example, with Jorge Gaviria and Adrian Gaspar, we are just writing up a book, a cookbook for Gyno 4D, a laser cookbook, mainly for gynecologists, because I am a gynecologist. 8 years ago when I met you, I was so skeptical regarding the use of laser in gynecology. Nowadays, I am enthusiastic just because I see the results of my patients. And I asked Jorge and Adrian to join me in writing this book, trying to induce our gynecologist friend to use to put a laser in their arms in order to improve the quality of life of our patients, because it is a very helpful instrument for the gynecologist. And the gynecologist can help the women with vaginal resistance syndrome, with atrophy, with incontinence, and why not? Also for aesthetic reasons, because aesthetic is not always only aesthetics. Aesthetics is also functional, and some women, they can suffer from changes in the aesthetics, and we can improve their quality of life.
Great, great. Thank you, Marco. Thank you for your comments and all of this discussion. It was great. And I'm also looking forward to see your cooking book coming out. And I think it will be a big help to our users. Thank you very much.
Thank you.
Drs. Meglic, Lasaleta, and Gaspar will present their experience in surgical and ablative procedures in gynecology. The session will be chaired by Dr. Fistonic.
I'm Assistant Professor Leon Meglic, Head of Gynecological Department at Gynecological Clinic in University Clinical Center, Ljubljana. My today's lectures have two topics. It's condyloma removal and ablation of the cervical surface due to specific problems like CIN and postcoital bleedings, both by using the micromanipulator ER100 from Fotona. I will try to explain both situations through the films, so let me share my screen with you. Of course, I hope there will be no special technical issues by that. So here we go. The first is on special condition, some special patient you can see by yourself in a few seconds. This is ER100 manipulator and connection by the erbium laser. And this is our patient. She is 24 years old and she is suffering first from the condylomas in such extent because of her rheumatoid arthritis and severe therapy by immunosuppressions. And this is our display. So we are using for now R11 handpiece, which is not really attached to the laser, but once again ER100 micromanipulator. We are in XLP mode, and our fluence is 42 joules per quarter centimeter. Frequency is 5 Hz, and the spot size is 3 millimeters, just to be sure what we are looking at. And once again, micromanipulator on the colposcope, so we have to aim and to focus, and then we can start doing. So her condition is really severe. What we are trying to do today is to remove some of those condylomas. Sorry for this poor video, now it's better. To remove some of those condylomas, just to establish her reaction to the surgery, her reaction to the start of removing those condylomas, not just her, but especially her body at this treatment. Later, we go by real big surgery like vulvectomy, through the perineum to the anus from one side and to the clitoris on the other side. But nonetheless, now I'm trying to show you this laser. We tried first, or secondly, a little bit different constellation. Still, we have R11 on the screen. Mode is MSP. Fluence is 8.4 joules per quarter centimeter. Frequency is still 5 Hz, and the spot size is 3 millimeters. What we are trying here to see or to show you is a different approach and a different hemostasis we can assure by using the laser beam. So same patient, same condition, but a little bit different approach. And you can see this is a little bit more bloody than previous constellation. So you will see, we will be soon back on the first. But you can see the laser is quite efficient on the skin, and of course we are sucking into the smoke evacuator the smoke from the skin. As you know, there is no evidence of DNA of the viruses in the smoke caused by evaporization with erbium lasers. Quite different with the CO2 lasers, where they found traces of virus DNA in the smoke. But of course, we still need to suck all the smoke to the smoke evacuator and through the filter. Now we are going back to the same position and constellation as we are, because of the hemostasis problems. You can see a very effective, very fast erbium laser, even faster and with more impact on the tissue than CO2. We can go around or through the condylomas to achieve the removing of them. As you can see here, this is what we are doing really in this case. We can, of course, discuss about a little bit later, but this is what we are trying to show you, a very effective erbium, much more than you are maybe aware of. bleeding is not the real problem here. We are very effective. We are very effective, as you can see. So one of those ways how to do it is go through the lesion, and the other one, of course, is to do just at the end point of the condyloma. Still, once again, very effective way to go through it. Almost immediate evaporization of the condyloma tissue, and very fast we are going through the skin. So we have to be careful by using. And now we are going under the condylomas to the basis, just to remove it all, with as small as possible damage to the tissue. Now we are going to our second goal today, and this is the vaporization of the ablation of the cervix. The most you can see here, there is the same constellation of our erbium laser. So R11 XLP mode, fluence 42 joules per quadrat centimeter, still 5 hertz of frequency, and 3 millimeter dot size. We are using special equipment like this speculum to be as good as a smoke evacuator. Also, of course, with the surface which is not that shiny on the inner side of the speculum. And of course, our beam are coming through the ER100 micro manipulator. The main thing at the cervix is that we have to have a biopsy and histological exam done to know there is nothing else but CIN1 or ordinary postcoital bleeding without any other disease, any other dysplasia of the cervix under it. That's the only safe way to do it. And you can see erbium laser very effective on this field too. Very fast, really. Not just by moving the spot. That's what I am doing, but we did going with the ablation, we did the depth of the tissue damage, which is really nice and quick, and the bleeding is really tolerable. So nothing to be afraid of. We can discuss it through the discussion, of course, also this part, but you can see a very effective way to remove. And once again, our constellation of erbium laser and a little bit of removal of the condylomas once again. Okay, now can I stop sharing this? That's really everything I wanted to tell you about. So you saw it's very efficient, it's very accurate, doing it by micromanipulator through the colposcopy and through the colposcope itself. And because there is not yet on the software ER100 put into the computer of the laser, we are using the R11 as our handpiece to manage this work by laser treatment. And it's safe procedure, and as you see, very fast. So totally comparing by CO2 lasers, which are primarily designed for destructions of the tissue. Thank you for listening to me, and have a nice day.
Soy Leticia La Saleta y desde España les envío un fuerte abrazo a todo Fotona. Gracias. Hello everybody, I'm Leticia La LA&HA. I'm a gynecologist. I'm happy to be here. Thank you for inviting me to participate in the 11th Fotona Symposium. And the title of this presentation is the evaluation of the effectiveness of treatment with neodymium erbium laser in women carrying the human papillomavirus, HPV, at the cervical vaginal level. With the advent of the molecular techniques in cervical cancer screening, we meet women who, even though they have HPV positive, don't present cytological changes. So this situation poses a problem in the consultation because we have to manage the patient's anxiety before these results you don't understand. And that's why we think that the treatment with the laser can be used to promote replacement cellular at the cervical and vaginal level and help to eliminate the virus. Last year we presented a project at the Balearic Island Medical College, and we were aware to be able to develop it. I would like to share with all of you a study we are carrying out in Palma de Mallorca. Here is the day that we have received the award scholarship of healthcare innovation. The cervical cancer is the second leading cause of death from neoplasm one malignant in women. But thanks to the cytological and molecular screening and biopsy, we can diagnostic earlier the pre-malignant lesions. The HPV infections of the cervix is very common, but can cause temporary changes of the cells of the cervix. It's a common virus that is spread through sexual activity. The relationship between cervical cancer and human papillomavirus was demonstrated to the early 80s. These temporary infections can cause temporary changes in the cells of the cervix. If infection of the cervix with a high-risk type of HPV persists, cells change can turn into a typical smear and precancerous lesions appears. Early detection and early treatment of precancerous lesions can prevent progression of lesions to precancerous or cancerous. Traditionally, the main diagnostic method are cytology, colposcopy, and histopathology. Molecular methods have now been introduced to detect the HPV. They are more sensitive. And now the methylation is studying the damage that HPV has caused in the DNA of the cells of the cervix. These studies can help to evaluate which patients are those with an increased risk of progression, the illness. The objective of this work is to evaluate if the impact of the treatment with the laser in the cervix in patients with HPV positive could be a good option. So we compare the molecular, cytological, and histological results. Here we have the methodology and program. It will take 18 months. Now we are in the 7th. The study area is in the city of Palma de Mallorca. We calculate the N. It's supposed to be 50 patients because of the number of the population of female in Palma. So the phases of the program, we have 3 phases. Now we are in the first one. We are selecting patients with the criteria inclusion. The second phase is writing, analyze the results of the statistical software. And the third part is to write the scientific article. Here we are in the first phase. We choose women between 30 and 65 years old. They will be asked for their consent to take part in the study. They are symptomatical. They are attending to the consultant for the annual gynecological checkup in the clinic Roger when I am working. We're doing a medical history, number of couples to date, usual contraceptive method, smoking conditions, number of children, previous etiologies, recurrent vaginal infections or not, and if they have been vaccinated. The patients must commit maintain relationship condom, only sex to minimize reinfection during the period study. The studies to do are cytological exams or pap test, HPV test by PCR. If the pap test is positive, we need to do the colposcopy biopsy, and patients with a medium-high semi-quantification will be considered selected for conducting a methylation study. And we're doing this study at the beginning and after 6 months of the laser. Oh, sorry. This is a photo during the colposcopy. A patient with HPV 16 and atypical cytology. We have 2 groups. One group is HPV positive and pap test normal. Second group, HPV positive, pap test abnormal cells, cytological and histological confirmation. Atypical squamous cells determined is the ASCUS, low intraepithelial cell changes, and high squamous intraepithelial atypical cells. Here is the laser. We use the SP Dynamis. We decided to put anesthetic cream 30 minutes before the laser. We need to clean the vagina and the cervix. We use a smoke aspiration, and the laser exposure will take place in the scamocolumnar junction inside the endocervix and all the cervix too. The first part, I use the erbium laser with R11. The protocol consists of the use of these parameters, 10 joules for square centimeters, and I try to deliver at least this quantity of pulses, 1,500 to 2,000 pulses. This is the amount of energy you will be delivering into the tissue. Not painful, at least nothing. The second part is with the neodymium R33 Versa piece or model. Here I start copying the podiatry model for onychomycosis, and I was trying with different energy. This one, despite of using the anesthetic cream, is a little bit painful. The parameters you can see in the photo. And here we have the third part, is with the neodymium YAG, with the fever of 600. This is a prototype piece intracervical that Senko sent me to do this trial. This is the piece, and in the photo we can evidence how can I use it. The parameters here is between 2.25 and 0.75. It's very slowly, not painful, and the pulses is between 50 and 300. Now there are some photos. We can see the laser treatment before, after, and post-laser, PAPS normal 6 months. It's possible to appear a little bit of bleeding, but with the correct use of local tranexamic acid or silver nitrate, it's enough to stop it. Another photos. And here we have the most important thing, is the partial results. Now we have done 30 patients since October 2020. The first group is HPV positive and PAP normal, 17 patients. 4 patients we did the control at 6 months and they were HPV negative. We are waiting for 6 months, the 6 months to repeat the rest of the patients. The second group with PAP positive and HPV positive has 10 patients, low-grade squamous intraepithelial lesions, and 3 patients with high lesions, seen 2 or 3. 5 of these ones were negative PAP test, not yet the HPV test, because only for the PAP test, because we check after 4 months because of woman anxiety and doctor too. And we wanted to know if the cells are okay or not. And we have done in these patients a little bit earlier. But one now is 6 months till the beginning, and the PAP test is negative and the HPV negative too. And now in the last group, we have 3 patients. We are waiting the time to repeat all the exams. They were advised and informed that if the PAP test will not become negative, perhaps need a conization. And we have done 10 methylation exams in HPV positive, mostly 16 and 18 serotypes. There are positives, and we need more time to have the conclusions with this topic and to design a follow-up in these patients. And perhaps in this patient, the results of the treatment would be perhaps a little bit different. We don't know. So, the last conclusions. We haven't finished the trial yet. We started 7 months ago. Need to have all the patients and results, and then we're going to have the final conclusion. The feedback is very good. All the patients are happy with the treatment because improved symptoms or discharge in the vaginal, and the negatives, obviously. And we hope we can finish it next year to tell you the final conclusions in the next symposium. Thank you very much for the support and trust in me.
Hello, everybody. My name is Adrian Gaspar. I'm going to share with you my experience using ablative, the G-runner for ablative procedures in gynecology. We all know that there are certain lesions at the level of the vaginal canal where sometimes surgical removal is indicated, and traditionally for laser vaporization, we've been doing these procedures under direct vision with a manual handpiece. And these type of procedures, in my experience, required an average of 3 to 4 weeks of sexual rest with the presence of inflammation and maybe risk of bleeding due to excessive vaporization. We have been using the G-set and also the G-runner for the same purposes to make a more uniform vaporization of the treated area per sessions in a less aggressive way, because first of all, we take advantage that the Irving jack can penetrate the glass, and secondly, because the placement of the speculum inside the vagina stabilizes the area to be vaporized so that the laser can perform a more uniform work in areas where sometimes it's difficult to target due to the presence of vaginal folds. It also allows us to carry out the complete elimination of the lesion in the vagina doing 1 to 4 sessions, depending on the size and the extension of the lesion, in a faster time, and as I've just said, in a more uniform way, and minimizing the risk of post-treatment bleeding due to excessive tissue vaporization. So this ablative treatment using the G-Runner allows the possibility to give to our patients a shorter downtime with a sexual rest of between 5 to 7 days and a faster recovery. When there are many areas, in addition, of certain lesion, the robotic laser vaporization can make the procedure faster and homogeneous. This is an example of what we have done in the past, the standard manual vaginal vaporization. And this is the way that we are doing with the G-Set. We can do it with the G-Set, either the G-Set or the G-Runner. Fotona has introduced 2 additional inserts for the G-Runner in order to enable ablative treatments as with the R11 G-Set. So we have, on the one hand, a 2mm full beam at the introitus with a direct GRD adapter to treat the introitus and the vestibulum, and then the 3mm full beam on the vaginal wall with the angular GRA adapter. So we can do the same procedure using the G-Set. But using the G-Runner, we've been treating vaginal HPV warts, condyloma acuminata, vaginal adenosis, vaginal endometriosis, and also vaginal intraepithelial neoplasia. So in relation to vaginal HPV, we all know that this type of lesion can cause pain, discomfort, itching. I'm not going to talk, it's not the scope of this lecture to talk about these pathologies, but we all know that currently this is considered one of the most common sexually transmitted infections. So there are various treatments for condyloma, focusing many of them on removing warts using different techniques such as cryotherapy, electricity, or scalpel. Of course, that some doctors prefer also to recommend some antivirals and to strengthen the immune system, but for these lesions in the vaginal canal, the use of the G-Runner is a safe and effective option. We have also published our experience using this G-Runner for the management of vaginal adenosis. So the clinical picture of the vaginal adenosis may vary, ranging from vaginal discomfort, pruritus, clear or mucoid discharge or dyspareunia. However, many cases could be asymptomatic. And this is the communication we have done last year or 2 years ago. In our clinic, we have treated 4 patients diagnosed with vaginal adenosis using the G-Runner. In this particular case, one of them was a woman, 36-year-old, patient who came in for discomfort, bleeding during intercourse with chronic leukorrhea and caused pruritus. So she had also 2 normal deliveries, and she had been using contraceptive pills since her last recovery. So the histopathology confirmed the diagnosis of vaginal adenosis, characterized by the presence of these typical glandular tissue or its secretory products. After 3 treatment sessions, separated by 10 days, she reduced her chronic leukorrhea, pain during intercourse, and the symptoms of bleeding had completely disappeared. So vaginal vaporization followed by coagulation using either the manual R11 handpiece, G-Set adapters, or the scanning G-Runner handpiece provides a minimally invasive and cost-effective therapeutic option for patients with vaginal adenosis. Other type of patients that we've been treating was vaginal endometriosis. We all know that these type of lesions, once diagnosed, has to be vaporized to minimize the risk of pain, bleeding, discharge, etc. Another lesion is the vaginal intraepithelial neoplasia. The vaginal intraepithelial neoplasia is a precancerous change in the cells of the vagina. Many cases of low-grade vein 1 will go away on their own, so some doctors prefer to control with doing a close follow-up of the patient. In our particular experience, we prefer to treat these type of patients. Also, vein 2 is unlikely to go away on its own, so treatment can be started immediately. Even so, it could also be simply monitored and begin treatment if it persists. I insist, we prefer to treat this type of patients. The treatment of vein is often using topical therapy such as 5-fluorouracil or imiquimod, or laser treatment. When there are many areas of vein, intracavitary radiation brachytherapy can also be used. And surgery may also be used in treatments where this type of lesions tends to have a recurrence, or if we have a doubt that maybe an area with invasive cancer. Surgery may consist of a wide local excision in which the abnormal area and a border of surrounding normal tissue are removed. A partial vaginectomy is rarely needed to treat vein. In the case of vein 3, which is the in situ carcinoma or stage 0 carcinoma, the usual treatment option here is laser vaporization. This is what is standardized to be done. So we recommend to start using the G-runner for this type of lesions, such as also the use of brachytherapy, because we are vaporizing certain segment of the vagina, the upper third, the middle third in a more uniform way. Topical therapies such as 5-fluorouracil cream or imiquimod is also an option, but these often require weekly treatments for at least 10 weeks. If the cancer comes back, then, well, surgery may be needed. This is an example of what we have done in our clinic. We treat a vein 2. You see the lesion here, before and after. We vaporize the whole upper third of the vagina. So G-runner offers the advantage of being able to access in an homogeneous and uniform way to areas of the vagina that sometimes cannot be well reached due to the presence of mucosal folds, or because it is in a vaginal area where we cannot control under direct vision a complete and uniform vaporization of the lesion. So the protocol consists of 2 steps. Step 1, vaporization. Step 2, coagulation. These are roughly the parameters for the G-runner and for the G-set. And I will show you the particular parameters we've been using in our clinic. So here we use the 3 millimeter spot size in the GRA-AB, which is the no rotation setup of the G-runner. And this is the parameter we have been using for example, an area with vein. MSP 8.4 joules and 10 hertz, 12 or between 10 to 12 hertz. For adenosis, we prefer an SP because tends to have more bleeding, and we increase the fluence and the frequency. But you can range from 8 to 10, depends on the extension of the lesion. To vaporize an HPV in the vaginal canal, we prefer to use MSP. HPV tends to have less bleeding with 10 hertz, 6 joules. For endometriosis, we use also SP because it tends to have more bleeding, 10 joules, 20 hertz. And then the second step for coagulation, we use smooth mode, and we use the rotation setup, the GRA-FG. So this is the handpiece, and this is the parameter. We have different fluencies for coagulation, 1.5, 175, 2 joules. We named coagulation 1, 2, and 3. And you can use between 3 to 3.3 hertz. So instructions: careful examination of the area to be treated. We need to confirm the diagnostic doing a biopsy. We do an anesthetic infiltration with lidocaine with epinephrine 2%, and we have to wait 15 minutes to achieve the maximum effect of the epinephrine to diminish the risk of bleeding. Dry the area before doing the procedure and use a vacuum. Adjust the parameters and insert the G-runner, adjusting the extension to work in the desired area. We have to perform the vaporization, the step 1, with multiple passes until we have bleeding. Perform then examination under direct vision with good light, dry the area, and determine if it is necessary to do a touch-up immediately. Then carry out the coagulation, step 2, using 1 to 3 passes. And then we insert the vaginal packing with gauze and Vaseline that is removed in 24 hours. Post-treatment and follow-up, topical hyaluronic acid gel is daily used at bedtime 24 hours after the procedure for 5 days to speed up the healing process. And depending on the extension of the lesion, multiple sessions may be needed. In some cases, we've been using up to 4 to 5 sessions. The sessions should be done weekly or every 10 to 20 days, depending on the diagnosis and each particular case. So I can perform an homogeneous vaporization because I have just said I can vaporize the whole upper third of the vaginal canal in a uniform way, and then carry out the coagulation. As a conclusion, the Fotona Dynamics laser system, equipped with an R11 set or G-runner accessory, provides a minimally invasive option for treating various gynecological lesions, particularly when the lesions are present over extended superficial vaginal areas. Examples include vaginal adenosis, vaginal HPV warts, condyloma, vaginal endometriosis, and any degree of vaginal intraepithelial neoplasia. Thank you very much.
So hi everyone, welcome to the discussion part of our session. It is very nice to see you all. Unfortunately, Dr. Gaspar could not join us as he was held in another meeting. I would like to present the chair of this panel and a person who will lead the discussion today. He's one of our expert users and pioneer in the use of Fotona smooth technology in clinical practice. So Dr. Ivan Fistinic, he's from Croatia.
Hello, all of you.
Ivan, please, the word is yours.
Thank you very much, and I'm very pleased to join you in this discussion after we saw videos and presentations from Professor Meglic and Dr. Letizia Lazzaretta, and it is really very exciting to be here in this surgical and elevative procedures in gynecology session. I would like to address a few questions first to Dr. Lazzaretta. I wonder, dealing with these groups that you presented here, you had two groups. One is HPV plus and PEP test normal and negative for abnormal cells, and the other is HPV and PEP smear positive plus high SIL. So I wonder, because you said that in group 1, you found 4 patients without any HPV after 6 months follow-up. But yes, my question is, what was the age range of your patients in the group 1? Why I'm asking this question? Because due to the immunological answers in the body in the group of women between 20 and 30 years, they may dismiss their HPV without any therapy. Of course, they have to act sexually very serious. So what was the age range in first group?
In all of the study, the age is between 30 and 65. We choose this age because of these things that perhaps the immunity can let the HPV go out. That's why all of the patients in the group are between this age.
I understand, but these 4 patients that were HPV negative, what was their age in the first group?
Between 30 and 40 and 60.
They were younger.
At the end, I will have all of the results, but we don't use the patients between less than 30 years. That's one of the reasons.
Okay, I have the second question, and please, Leon, join us here.
Yes, sure.
My second question is dealing with the group 2.
Yes, in the 2 groups, I want to say something. You say that all of them have high SIL, and no, only 3 patients have with high SIL.
Okay.
And the other one, all of them is low SIL.
Low SIL.
Only 3, but we accept these patients because they don't want to have a surgery. That's why yesterday I have done the pap test for one of them. I don't have the results yet. But the service is perfect. It's nice.
But they signed the form consent here that they will risk. I mean, why? Because in Leon's in Leon's session, he stressed that he's treating patients with red spot, of course, but till the level of CIN1. And my question is, if you treat CIN2 or CIN3, which is near carcinoma in situ, there is a possibility that you will cover some niches that are down there, and you will cover the, let's say, carcinoma that will blow up in some time. That is my question.
Yes, I don't think so, because the cervix, all of them are now one. Yesterday I have done one, and it's the cervix. I can show you a photo if you want. the patients know that it's a risk. That's why I say you need a conization, and they say I don't want a surgery because.
Okay, but did you have a biopsy after?
Yes,
this
after
remission? No, not before. After.
Not yet. Yesterday I had only the first one.
Okay.
That 6 months later I need to do it.
Of course. Leon, what do you think, Leon? What do you think?
Well, it's a really very risky business because I do have a knowledge from our clinic of 3 patients, just the same story, CIN2 and CIN3, some 5-7 years ago, and then total normal pap smear because, of course, you are taking the pap smear over the scar. So there is normal tissue, normal cells, but under it, there is a room for cervical cancer to grow. And we have in past 3 of those patients, so we stop doing this even at very young patients. So any scene 2 and scene 3, where it is an indication for.
I do agree with you. Tell me, Leticia, do you have ethical committee approval?
Yes.
You have. Okay.
Yes.
Okay.
Yes, and they gave me I don't know how to say award from the colleague of medical colleague of the Balearic Island. Yes. That's what we're doing.
Okay.
Time we're checking all of the patients. They are my patients from a long time. And they know everything. And I'm taking photos all the time. And yesterday I have done one. This one is a very special patient because she has the vaccine and she's 16 and 18 positive, the HPV. That's why it's very, I don't know what happened with her, what will happen.
Now let's move to the this new entry of new handpiece that you used in intracervical application of Nd:YAG. So this is a brand new thing, Neja. Am I right?
This is a, let's say, a pilot, a specially designed handpiece for this trial.
For this inside, so it is circular Nd:YAG.
Yes, it's actually designed on the basis of the intraurethral cannula, but it has a conical golden mirror at the end, so I think it makes it circular. Yes, exactly.
Okay, so my question is, do you perform cervicometry by ultrasound before you enter the cervix or not? And how many passes do you perform?
That is it's not a problem, but I don't know sometimes because it's very slowly, because it's with the fever. So I put and all the time doing like this. Normally I do 6.
6?
Yeah, because it's 3 centimeters and I go to the back and come back. But it's new. And the parameters, I am changing them because at the beginning, Senko, because we are thinking 1. But then I am trying a little bit more energy. I think it will be better.
Okay. Now I have a question for Leon again. You showed some parameters there, and you showed that you changed something in order to have in one session, not to changing parameters, both ablation or vaporization and hemostasis.
Yes. But to my experience, the hemostasis is better when I choose the XPL mode.
So longer.
Yes. So we stick to this now. There is no more trials, and but that's it. Somehow.
And tell me, I wonder what happened with the patient. I mean, it was extreme.
Well, we have a surgery, a serious one, vulvectomy, to obtain the better possibility of hygiene. So we are removing from the anus, from the vulva, let's say 2/3 of those condylomas, but we cannot do it all together because it's too much. So we need now to heal everything, and then the corona struck.
Of course. So, tell me, how long? What was the time gap between your the date when you presented and you made this evaporization and surgery? How long time?
About a month.
Okay, so I wonder, those lesions that you cut by a laser,
yes,
is this on the gluteus on the left side?
Yes, right.
I saw that that it was pretty deep.
Yes, it was.
So I saw also the fat tissue under the skin.
Exactly.
So you ablated all the skin. How did it scar?
Excellent, really. Especially due to her treatment, due to dexamethasone she taking all the time. And despite all that, of course, the skin is very thin, but still the scar was almost complete. I do have somewhere some photos prior to this operation, where we can see those.
But tell me, did you have to perform some dilation of cervix before you entered with the probe or not?
In one patient, it was a little bit difficult. I put another appointment and put a cytotec. Do you know what is cytotec?
Yeah, sure.
Local anesthetic?
No, local anesthetic, see. Yes, sorry, but I put something. It's a pill that we use normally in the miscarriage.
Yes, yeah.
In one patient only was necessary, but the other ones no, because it's very thin. The piece.
What is the diameter, Neja? Neja, what is the diameter?
4 millimeters.
4.
4. Yeah.
It's same as
it's the same as
intraurethral.
Yeah, it might be maybe 5 because it's a bit wider at the end, but between 4 and 5.
Painful, nothing, eh?
Okay.
I have a question, if I may, just a bit back on the topic for Leon. Do you think it was necessary to go this deep for the patient that you treated when we saw the fatty tissue? Is this necessary, or you could go more slowly? And
we could go, of course, more slowly, but this is the special case of a special patient.
Okay.
And there was really two possibilities. One, not to go that deep and let those condyloma to rise again, because there is almost no immunity against the HPV. This is the one reason. And the second, very thin skin. So almost after the first or two pulses of the RB laser, we are through the very thin skin in the underlying tissue. So yes, I would prefer to maybe less damage, but on the other side, it healed very, very well. So I'm pleased with her.
Sorry, I have just another question. I'm really interested. How many patients do you treat with this per year, for example, at your practice in the UKC?
With that severe cases?
Not that severe, in general. With erbium.
With condylomas?
Yes, with condylomas, for example, and then also with SIN.
Oh yeah, well, we have with ablations altogether, we use the laser, let's say it should be, it should be 300 or 350, all of them.
Leon, is it covered by health insurance in Slovenia?
Yes, totally.
Oh, perfect. That's nice. My experience is also for long years, I treat these genital warts, and my experience is really, I'm very satisfied, because the most important is that you will avoid bleeding, and scarring will be very fast without depigmentation, which is very important. Not this your severe situation, but in average, a lady who has a few condylomas, it is perfect scarring without depigmentation, because if you use electrocoagulation or something, you will get depigmentation. By erbium YAG laser, no depigmentation.
Yes.
Yes. Very good point.
Thanks to the panelists for providing your insights on these very important but often really overlooked applications. Thank you, Ivan, for chairing this session, for joining us, and stay well, and hopefully I'll see you soon. During a session on other emerging applications, 3 of our expert users, Drs. Erel, Lazaleta, and Gaspar, will present their experience in expanding the use of laser in new applications. The discussion that will follow will be led by Dr. Novako Mikic.
Hello, dear friends and colleagues. The topic that I would like to mention today is vulvodynia. Vulvodynia is defined as vulvar discomfort, most often described as burning pain without relevant visible findings or a specific clinically identifiable neurologic disorder. It may be felt only during sexual intercourse. It may be triggered by non-sexual activities such as walking, cycling. Vulvodynia should persist more than 3 months, and it's quite common among women. It may be general or local. General vulvodynia specifies involvement of the whole vulva, and local vulvodynia involvement of a portion of vulva, such as vestibulodynia or clitoridynia. It may be provoked or unprovoked. Unprovoked implies discomfort that occurs spontaneously, and provoked implies a discomfort caused by physical contact, such as sexual intercourse, clothing pressure, tampon use, cotton tip or fingertip pressure. According to the classification of female sexual dysfunction, vulvodynia is a genitopelvic pain penetration disorder. It may cause dyspareunia or vaginismus. Therefore, the severity of vulvodynia may be assessed by provoked visual analog scale. And some questionnaires also helps us to understand the impact of problems on quality of life in women. Most of the etiologic factors causing vulvar pain related with the dermatological, infectious, inflammatory, or neoplastic disorders should be excluded. Therefore, the differential diagnosis is important in the evaluation. Evaluation of psychosocial effects is also important. Her depression, altered body image, impaired social relationships, altered sexual function, difficulty in physical daily activities of life, and vulvar care measures should be asked. And the classical treatment choices for vulvodynia ranges from the topical medication, oral medication, to surgically wide excision of the vulva. Here I want to present 2 cases of vulvodynia. The first one was published in European Journal of Obstetrics, Gynecology, Reproductive Biology in December of 2018. She was a 43-year-old woman. Her presenting symptom was pain just beneath the labial fold during penile penetration and insertion of tampon. Her pain just started 6 months after her last delivery, but the last 6 months severity of pain gradually increased. She was describing the pain as something tears when the penis or tampon touched to the certain area outside the hymenal orifice. She started to seek for the solution of the vulvar pain before coming to see me. She was treated by antifungal cream, topical corticosteroids, anesthetic creams, and many times by different doctors for more than 4 years. She used to use antidepressant drugs. Finally, she was offered vestibulectomy. In her exam, there was a tenderness area on the commissura posterior, and this tenderness area extending along with the right mediolateral episiotomy scar. Provoke Q-tip visual analog scale was 7 out of 10. I marked the painful area. First, I provoked the Q-tip test, and I understand the painful area, and I marked there. Then I applied 5% lidocaine cream 30 minutes before the intervention. Erbium-YAG laser beam was directed to the area where the pain was provoked with the cotton tip, a PS03 handpiece I used with a fluence of 10 joule centimeter per square, 1.6 hertz with 7 millimeter spot size with 3 or 4 passes. Secondly, I directed the erbium-YAG laser to episiotomy scar. 3 sessions at 4 weeks apart. In each session consists of 5 joule per centimeter square, 5 hertz, 5 millimeter spot size with 4 shots in each point, and I used PS03 handpiece. I did 2 or 3 passes. In addition to that, erbium-YAG laser in the smooth mode with the PS03 handpiece, I applied the energy with 10 joule per centimeter square, 1.6 hertz, 7 millimeter spot size with 4 shots in each point. And 8 months after the treatment, aesthetically, the appearance of episiotomy was quite satisfactory for the patient, and her visual analog scale was 0. The second case, she was 22 years old young girl. She had a condyloma just on the commissura posterior of the vaginal fourchette and was treated with Aldara cream. She had a regular menstrual period. She had no history of pregnancy and no use of oral contraceptives. Several times she had received various kinds of local or oral antibiotics for the treatment of the vaginal discharge. Her presenting symptom was pain and light bleeding in the commissura posterior around the hymenal orifice after each sexual intercourse. Last 3 months, her pain prevented her to have sex. She had also pain when she wore tight garment. In the exam, no vaginal discharge was detected, and skin covering the commissura posterior region of the vestibule was thin and pale. Here you can see the commissura posterior, and there is some area just on the vestibule surface on the right side. You can see the mucosa, how it is thin and pale. Provoke Q-tip test, visual analog scale was 9 out of 10, and her FSFI score was 18.8. In order to treat the pain around the hymenal orifice, I used R11 handpiece in smooth mode, 6 joule per centimeter square, 1.6 hertz, 7 millimeter spot size with 4 shots, 5 passes, and also I applied PS03 handpiece with smooth mode, 10 joule per centimeter square, 1.6 hertz, 7 millimeter with 4 shots, 5 passes. For commissura posterior, I choose to use PS03 handpiece with smooth mode, 10 joule per centimeter square, 1.6 hertz, 7 millimeter spot size with 4 shots, 4 passes. She completed 2 sessions of laser therapy by 2 weeks apart. At the end of 2 months, her pain was evaluated by visual analog scale, and it was 0. And her FSFI score was 33.6. These two cases shows us definitely vulvodynia is another indication for the application of erbium YAG laser. So thank you for your attention.
Hello, everybody. I'm Leticia La&HA. I'm a gynecologist. I live in Mallorca, Spain. I'm from Argentina. And I'm very happy of being part of this Fotona family. Thank you for inviting me to present this work. The title is the effect of subablative erbium YAG laser on vaginal microbiota for the management of vaginal dysbiosis in menopause women. The question is, does erbium YAG laser work in vaginal dysbiosis? When I was doing these procedures that we everybody know here in this Fotona family, the incontinence, intimalase, prolapse, renovase, and condylomas, and now the new one from the candidiasis. All of them works, and we know that. And we wanted to know if the laser works in the microbiome of the vagina. So during all of these procedures, like a gynecologist, many women commented that after the laser sessions, they noticed the improvement of many symptoms, menopause symptoms, and infections, urinary infections and vaginal infections like vaginitis. Some of them told me that their vaginas smell again like younger times. So thinking and talking with another doctors from this family or Fotona users, we decide, or we think to do this work to have more information and have the evidence to use the Fotona, especially to find changes in the vagina microbiota. So before telling you all of the results, I'm going to introduce a few important topics. I'm going to explain you the loss of estrogen production during the menopause causes the thinning of vaginal epithelium, change of exfoliation cells, loss of mature superficial cells. Most cells are immature parabasal cells, pouring glycogen content. In this graphic, we can see the difference, these things that I'm telling you. Then in this graphic, we can see that the loss of glycogen produce loss of lactobacilli and lactic acid, increase in vaginal pH, change in bacterial flora is mixed, and increase the risk of infection and inflammation. All of these changes cause in the woman the vaginal dryness, dyspareunia, pain, irritation, itching, dysuria, problems during the intercourse, and the infections too. How the laser works to change the microbiome. The thermal effects of the laser stimulate the fibroblasts, produce mature collagen and new elastic fiber, increase angiogenesis and vascular flow. And when the nutrients arrival of the extracellular matrix, produce hydration and regeneration of the vaginal epithelium. And all of these changes works or helps to put the colonization of the lactobacillus. So the aim of the work was to prove if the laser can change the vaginal microbiota. So I want to tell you how we designed this protocol. The summary of it was only 20 women between 50 and 70 years old with menopause symptoms, which with SGM, we have done 3 lasers, interval 1 month between each one. The follow-up was at the 3 months, the first one, and the second one between the 6 and 8 months. Then the parameters we have chosen is here. They are here in the photo with the 11. We needed to use the local anesthetic because at the beginning, some of them feel a little bit of pain. Then we did the follow-up, the first in the 3 and 8, 6 and 6 months after the laser. At the beginning, 3 and 6, we have done pap test, culture test, Then the questionnaire, we use the female sexual function index, the ICQ short form, and the visual analog score used for scoring severity of vulval vaginal atrophy symptoms. And the results, here we are. So, with the pap test before the laser, all of them was informed like atrophic vaginitis or pap atrophic, with parabasals and metaplastic cells without superficial cells. And after the laser, most of them have presence of intermediate cells and some superficial cells. Here we have the pap test after laser. We have the first control, it was 3 months, and 81% the pathologist informed that they were normal, and the other 19 not atrophic, just intermediate changes. And the second control, it was 6 or 7 months, still normal, the 73% of the patients, and 27 with intermediate changes. It's not atrophic, but still a very good percentage of good results. The other topics that we were doing is the questionnaire, the FSFI, improvements, the items of lubrication, satisfaction, and pain. There were improvements in many items. It was evidenced by the questionnaire that by improving the vaginal symptoms, the sexual activity also improved. I'm going to show you now a graphic. The ICQ short form, only 60% had urinary incontinence at the beginning of the work, and all of them presented improvement after 3 sections of laser. And the visual analog score show less atrophic signals. So here I'm going to show you before laser and after 2 sessions of laser. In these patients, 60% no sex at the beginning, and with having sex only 32%, I think. And after 2 sessions of laser, increase the number of patients that started to have sexual intercourses because they feel better, obviously. And here in the visual analog score, we have the improvement of dysuria, vaginal dryness, vaginal bleeding, vaginal itch. Here is the how we receive the culture test. This is from Teletest from Barcelona. And here we have the pH. The black column is the results, and the yellow ones is the reference value. So the healthy vaginal microbiome that we want to have. So here in the first cycle, we have the lactobacillus, and here is the lactobacillus crispatus, gasseri, jenseni, iners. And we can see here in this patient, we don't have, or she don't have any of them, didn't have any of the lactobacillus. Here is the bacteria, acid lactic, and bacteria no acid lactic. Here the candidiasis. Now we can see, I am showing you 3 patients that before laser and after laser, we can see the difference of the distribution of. This one is lactobacillus, 7%, and here 37%, the pH 7 and then pH 5. These are the lactic acid bacteria, and it's not increased. And in the other ones is the same pH change, and the lactobacilli group, it will get better. Here we have again the media before laser and after laser. It was 11% for the lactobacillus, and after the 2 sessions of laser, it was 55%. And now here is publication in the Cell Press and clarify how with the laser we can put the dysbiosis in the vagina to put in a healthy state with the Lactobacillus crispatus, Gasseri, and Henseni. So the conclusions of our work was that the GSM affects 50% of our menopause women, negatively affecting their quality of life. And with the laser, we can help them to manage the genitourinary symptoms of menopause because can change the microbiome positively. The fractionated laser has clinically, microbiologically, and histologically demonstrated the regeneration of the superficial epithelium similar to that produced with local estrogen, and no significant adverse effects have been reported. Only I have a few ones with a bit of bleeding during the first laser, and after it a few days, painful, perhaps a little bit. We're using 2% of the patients PRP with successful. It was a successful idea because they support better the laser and the results were perfect. So here we can say that well-designed clinical trials are required to provide quality evidence of its promising therapeutic effects, duration, and long-term effects. So thank you very much to all of you to be here, to invite me and my colleagues, because they helped me a lot. Thank you. Bye.
I'm going to talk about my experience in the management of pleasure enhancement using the hyperstacking of smooth pulses. So this is a laser improvement of clitoral sensitivity. We know that with the arrival of menopause, there will be certain problems such as the lack of sexual steroids, such as estrogens, testosterone, dihydroepiandrosterone, and will promote the decrease in trophism, not only in trophism, but also the ability to respond to stimulations of erogenous areas. So based on the demonstrated regenerative effect that we can achieve with the Erbium Smooth Laser, we are treating patients who consult us about this problem in a novel protocol with subablative Erbium laser. So the question is, does the clitoris really age? Are orgasms affected by aging? Well, actually, there is a clitoral aging process. The clitoral sensitivity will be dramatically affected in certain patients. It is the only organ, the clitoris, that its only function is to give pleasure. It has absolutely no reproductive function. So it loses its responsiveness after hormonal decline. With the aging process, decreases its ability to congestion and response to stimulation. And just to have an idea, there are more than 8,000 nerved endings in this area that will be all affected according to the lack of trophism in the organ. So it has been demonstrated and well established that with the aging process, there will be lack of androgens. And this lack of this diminishment in the androgen levels in adult females change with age, and we will have as a consequence of this in a great number of our patients an hypoactive sexual disorder. So Erbium Smooth has the ability to reverse the atrophy, to improve the trophism, improving the local blood perfusion, initially by promoting a vasodilation, and secondly by promoting angiogenesis. And also, we are strongly convinced that we can improve neurogenesis, so new nerve fiber terminals, and reactivate the sensitivity in this way. And then we can keep the benefits of the treatment over time by doing touch-up sessions. So these are the anatomical areas that have to be approached. So the glands, the corpus cavernosum, the cross of the clitoris. So this is the reason why when we do laser, our laser protocol, we deposit certain amount of energy in all these areas, in all the not only the glands, but also in all the whole structure. So our research strategy was to confirm our initial findings with other colleagues and a small number of patients, analyze results, and confirm the need to research for alternative improved protocols. If necessary, make proposed adjustments and retest in a small group of patients. Once the protocol has been tested and confirmed, recruit a large number of gynecologists to participate in a multi-center research study to convalidate our findings. So, treatment objectives of this protocol: improvement of genital sensitivity, a faster response to sexual stimulation, improving frequency and or intensity of orgasms. So this is our background. 5 patients were treated as a test sample following the research protocol of hyperstacking of smooth pulses. The results, we evaluate the results, the degree of patient satisfaction, we using the 5-point Likert scale from 0 to 4, where 0 was completely dissatisfied and 4 was completely satisfied, with an average of 3.2 on the 5-point scale in an improvement, as an improvement. So no severe adverse events or complications were observed. The treatment was very well tolerated using a numbing cream. Our preliminary results suggest that the use of hyperstacking of smooth pulses could be a safe and effective treatment to improve clitoral and vaginal sensitivity. The participants in this initial research were different doctors: myself from Argentina, Dr. Marco Gambacciani from Italy, Dr. Larissa Mitro from Brazil, Luis Carazo from Costa Rica, and Juan Bojanini from Colombia. The inclusion criteria were women who have lost or diminished their sensitivity during intercourse and wish to improve it, and women who have sexual activity at least once every month. There was an extensive exclusion criteria, such as you see here: patients with severe dryness and atrophy, anorgasmic patients, pregnancy, urinary infections, etc. The laser protocol: we applied topical anesthesia with lidocaine gel 5% 5 minutes prior to the procedure. As this is a mucosa, it can be numbed faster. Carefully remove the gel and dry the area before starting the protocol. The protocol consists of 2 steps. Step 1 is the treatment of the vaginal canal, but we treat only the middle and lower third of the vaginal canal, so 50 millimeters of the vaginal canal, using Erwin Smooth PSO3X 7 millimeter spot with the GI extension. And the fluence we've used was 4.5 joules. We delivered 7 shots with the glass probe and 4 shots in the metallic probe, and we did 3 passes, delivering the energy every 5 millimeters. For the second step, which is one of the most important, because the first step treats basically the G area, the more sensitivity, where we normally apply the G spot, where we do the G spot amplification, but here we do the laser protocol to improve this, the vascularization at this level. But the step 2 is the treatment of the external genitalia and the vestibule, where you see we treat all the structures that, all the areas where all the clitoris structures are represented or covered. So we have been performing treatments with different parameters, trying to determine which is the safest and most effective protocol. In this sense, although the results have been positive in almost all of them, both with the use of R11 and with the PSO3X, the initial objective was to test the hyperstack technique in the genital area for pleasure enhancement. Both R11 and PSO3X were tested with low fluencies and stacks from 9 to 36, using frequencies of 1.6 Hz with spot size of 7 to 7 millimeter spot, 5 to 7 millimeter spot in this step 2. So the clitoris has to be manually exposed at the moment of the laser irradiation by retraction of its hood, in order to assure a good penetration of the hyperstack pulses. We did 3 sessions, performed 1 every 15 days, and touch-up session if necessary every 4 months is recommended, but in this session was not included in this initial research. For the purpose of this initial study, treatment should not be combined with other protocols such as intimalase, renovalase, in order to avoid confusion on the source of the improvement. The treatment evaluation, we did an initial brief sexual satisfaction questionnaire in patients, 2 types of questionnaire. The first questionnaire at the beginning, and the second questionnaire was conducted 30 days after the last treatment, confirming first that the patient has had at least sexual activity once. So this is the first subjective evaluation. Do you climax? Do you have sensation? Tell us about your level, how is your level of excitement compared to orgasm you have in the past, how intense is now? Did you notice an improvement? If you experience change, how intense was this change? Please describe the most relevant changes. How comfortable do you feel with the treatment? How satisfied are you with the treatment, and so on? Our preliminary result of the 14 reported patients, 9 noted an excellent change, 2 noticed a slight change, and 3 did not notice any improvement. So, conclusion, our preliminary results suggest that the use of subablative Erbil Smooth could be a safe and effective treatment to improve clitoral and vaginal sensitivity in women after menopause, having this concern or not. And if for any doctor who is listening to this presentation, I would like to join me in this multi-center study that we are starting now, please send me an email to researchgaspar@gmail.com in order to include you in this research protocol. Thank you very much.
Hello, everyone. We are opening now the discussion for a session of other emerging applications. And on our panel today, aside of myself and Neja, we have Professor Alexandra Novakov, who is the chair of this session. We have Professor Tamer Erel from Istanbul, and we have our dear doctor from Spain, Letizia Lazaleta. And Alexandra, as the chair, will start this session and also start with a few questions for the presented speakers. In fact, we should have one more speaker presented in this discussion, and this is Dr. Adrian Gaspar, but unfortunately he was not able to make it at this time slot. So Alexandra, the floor is yours.
Thank you, Zdenko, and I would like to thank Fotona and organizers for making this possible. We all know how important our meetings are in order to be updated with emerging appliances and what we can do with our lasers. And fortunately, this unfortunate situation with COVID has not stopped us to find new languages, new methods, and new applications. We have been in touch for this year as well. And I'm very happy to be hosting and co-chairing with Zdenko this session, because it is really the emerging applications that are one of the most important things in developing the use of lasers. And it is the pioneers and brave people like Leticia and Professor Tamar that are expanding the possibilities of use of laser. So for Leticia, for this lecture, if you can tell us again just the name of the lecture in full, that would be.
Yes. The title is Effect of Subablative Erbium YAG Laser on Vaginal Microbiota, but for the management of vaginal dysbiosis in menopause women.
I think that we would agree that the topic of and the field of microbiota is one of the most important fields in science now, because we are trying to understand and to use the bacteria that we are hosts of in order to defend ourselves rather than use the medicine. And it is in this course that you developed your study. and the results are really, really very good.
Yes. Yes.
Now, there is something that I am quite interested in, and that is when you say that Pap smear was normal, and you say that somewhere in results, you also say that the intermediate cells are starting emerging after laser session. And when was the first session, when was the first time that you saw intermediate cells in your Pap smear?
Normally, during the study, we need to do 3 Pap tests. At the beginning, after the 3 sessions of laser, 3 months later, and then 6 months later. So we wanted to know if the changing is still going better in the first control and in the second, because the symptoms, they are very good. So if we stimulate the collagen, all of the cells, they start to have fluid from the vagina, smell again like vaginal younger time, like a lot of women say us. In this moment, the pathologist, the doctor, put at the beginning atrophic and then normal, but we want to know exactly the cells. That's why they then, because we ask the doctors, explain a little bit about the cells. Because if we do a normal Pap, they put normal or atrophic and nothing else. And then they put a bigger describe of the Pap test.
I see. And it was 3 months that you already saw. After 3 months, at the control, after 3 months, you saw the
Yes, the first one, yes.
Okay. And when you saw the difference, does that mean that all of your women had atrophic vaginitis?
Yes, because normally we don't use the laser with the patient that don't have symptoms in this study, because we want the people who have symptoms. If they are using TRH or estrogen or hormones or another medication in the vagina, perhaps they are not feeling the same symptoms that if they are in the menopause with the syndrome of the symptoms.
So the inclusion criteria was atrophic vaginitis, and the exclusion criteria was use of any other topical.
Yes, it can be exclusion. We select the people that not using, because if you use another thing, we don't know if it's the laser or the estrogen.
I see. Okay.
That's why, because now we have another medication to use in the atrophic is the intrarosaprasterona. We use a lot of this medication, but in this case, we don't want the woman to use this because we can know if this is the laser of the drugs.
I see. And there is one more question about this study. When you look at the microbiota, what was the most the factor that changed the most? Was it the pH, or was it the lactobacilli, or was it the less of the pathological species? What is the science behind that? What did you see that changed most?
Yes, in the culture test, in this one that we choose, the teletest can put the difference between the pH, lactobacillus, bacteria, and candida. And in all of them, the pH, it was a little bit better because not all of them have not acid vagina at the beginning, but most of them have a little bit better. And the lactobacillus increased in all of them. And the candidiasis too is a little bit low. We have the columns. You remember the picture?
Yes, yes, yes.
The candidiasis, we have the column. The yellow ones is the correct or healthy vagina, microbiota, and then the results. And they stay in the normal state of, or the quantity of the all of the herments.
I see.
So this, and normally they smell the fluid and not have symptoms or not have infections during this time, because at the end, it was like 9 months beginning, 3 lasers, pap test and culture test. And then 3 months later, it was 9 or 10 months.
I see. And would you say that that we can use PRP as well?
Yes, we use PRP into patients because the vagina was so atrophic at the beginning that during the laser sessions, they feel a little bit painful. We put cream with anesthetic. We need this one not because if they are a little bit small with atrophic, they feel painful. So we decided to use PRP into patients only. 2%, sorry.
Zdenko?
Well, it seems to be a very nice study, and discussing one of your questions, Alexandra, about the most expressed sign of change, I would say this is lactobacilli. So lactobacilli quantity there, which is normally almost on this round graphs, almost 100%, went from few percent to like 30, 40%, and this is significant improvement. This, I believe, is the major sign.
And I want to tell you something. All of the patients now are still going, my patients. So this year, they asked me to do, I need to do another session because I was too good last year. So I need to do it again, not to have infections, to prevent. They asked me.
So maintenance, they want maintenance session.
Yes.
That's great. That's great.
Actually,
so if they want to repeat, it was okay.
And that's actually a reality check, isn't it? Because if they enjoyed it, then they will come back.
Yes.
Any more questions or Zdenko?
No, I suggest we move to Tamer to see what you have to ask him about his talk.
Well, I would say that the talk is excellent, and I'm very happy that Tamar has turned to the painful part of the women's life, let's say, and how it changes the quality of life. So I congratulate on that, and I would like to ask, what would you think that we would need some kind of randomized studies, or just the observational studies would do patient by patient?
Okay, actually, I treated so far 10 patients, and I'm trying to establish my protocol by trying, but mainly the R11 SP mode is working very well. And then I change my protocol after this 2 case. I prefer R11 SP mode and 6 joule per centimeter square, 1.6 hertz. Now I prefer to use the R11 with SP mode, 6 joule per centimeter square. But first I apply the AMLA cream, 5% lidocaine. I'm waiting for usually half an hour, and then I apply the erbium YAG laser.
I see. Okay, we'll be waiting for your protocol then. We'll be trying this and then waiting for your protocol. And were there any side effects?
Actually, I didn't see any side effects so far. So the patients are very good. There is no, they didn't show any side effects so far.
Excellent, congratulations.
How many sessions? Because I didn't read.
I usually prefer 3 sessions with 4 weeks 3 weeks or 4 weeks interval.
Okay.
I just wanted
it is enough.
Yeah.
It is enough to treat the vulvodynia, and I didn't use any other applications such as PRP or etc.
You mentioned that you treated 10 patients. Are the results equally good as for the 2 you showed in your presentation?
I didn't show the presentation to get lengther, but the last one she had radiotherapy because of the cervix cancer, and she was 36 years old. She has a daughter of a doctor. Her father was a urologist. He was passed away, and after each intercourse, she feels very bad pain and also heavy bleeding. And I used R11 SP mode for 2 sessions. The bleeding stops, and then she has a wonderful sex life after this treatment, without any vulvodynia and deep paranoia as well.
Okay. I have one question. The age of your patients, these 10 patients, are they mostly younger patients or all ages?
This is important, and I have patients ages 52, 49, 42, 43, and my youngest patient was 22.
Okay, great. Thank you. In spite of all the troubles with the connection, I believe we succeeded to get answers from Tamer.
Yeah.
And I think it was good discussion with very interesting insights. So thank you very much for your participation, great lectures and great discussion. Thank you all.
Thank you.
Thank you. Bye.
Bye.
Last but not least is a session called Free Communications. We are very happy to share with you some of the best presentations from our users.
今日は私の発表を聞いてくださりありがとうございます。本日私が発表するのは人工知能の話です。人工知能といってもそんなに難しいものではありません。これは極めてシンプルなものです。最初のスライドです。これは327例の症例から VL の効果について経口スコアマッチングを用いて研究したものです。外来と話すときに重要なのはその治療の選択という問題になってきます。選択をするには全体のデータ、個人のデータ、この2つが重要なポイントになっています。全体のデータからはこの治療はどのぐらい効果があるとか、どの程度の副作用があるかといった質問がされます。一方で、個人のデータとしては、私と同じ人がどのぐらいいるのか、私はこの治療で治るのか、私はこの治療で治るのにどのぐらいの日数がいるのかといったことが質問されます。全体のデータとしては、ピサ大学のガンバチャーニ教授が研究された1万人以上のVEL の患者における安全性と副作用の研究といったものが挙げられます。一方で、個人のデータとしては、今回我々が発表したような経口スコアマッピングを用いて、それぞれの患者の特性からどの割合で治療効果が得られるかといった論文が挙げられます。我々が使ったような経口スコアマッチングという方法には、古典的な方法と機械学習による方法があります。古典的な方法は解釈が明確になりますが、機械学習の場合は解釈が不明瞭になる欠点があります。それでは、経口スコアマッピングの基本を見ていきましょう。我々が日頃、 研究する場合、RCT を行いますが、これは母集団のグループを均等に2つに分けることを意味します。しかし実際はこのような状態は臨床上存在はいたしません。こちらの図のように多くの患者様から医師の判断により A のグループと B のグループのように分けてしまいます。そうすると A のグループと B のグループを比較することが難しくなりますので、マッチングという技術が必要になってきます。それでは最初にマッチングする前の絵を見てください。A 群と B 群ではそれぞれ条件の違う人が入っています。これでは比較することは不可能です。そこでマッチングをしています。マッチングをすると同じ条件の人が A 群と B 群に出てきます。こうすれば A 群と B 群を比較できますね。この患者さんとこの患者さんです。マッチングについて勉強することができましたので、最初のレッスンとして治療とコントロールの2つの群についての傾向スコアマッチングを勉強しています。今回使用した言語は R です。EZR というパッケージングを用いて傾向スコアマッチングをしてみます。Excel を用いて患者データを選択します。この患者データは配布いたしますので、練習に使ってください。データを EZR にインプットしますと、そのデータについて確認することができます。データに確認したら、次は分析に入ります。今回の傾向スコアマッピングでは、性別、年齢、クレアチニン、在院日数、心臓の力、6分間の歩行距離、ヘモグロビン、肺活流量、そういったものを計算値にいて、在院日数について予測するようにいたします。先ほどの入力したデータのうち、連続変数と非連続変数に分けてデータのインプットをし直します。そうしますと、2群に関してそれぞれマッチングされたデータが出てくることがわかります。これによって傾向スコアマッピングのデータの抽出ができましたので、では実際に臨床にどのように応用するかイメージを見てください。彼女の望みを見てみましょう。こちらです。彼女56歳。これだけの条件が揃っています。その中で彼女が望んでいるのは、一体自分は何日入院することになるの？ A の治療なら何日ぐらい、 B の治療なら何日ぐらい。全体のデータは分かった。さて、私とそっくりな人は過去いなかったかしら。そこで、傾向スコアマッピングで彼女のデータを引き出しますと、彼女そっくりな人が2人手に入ります。このようにデータを見つけることで、2人の患者が自分とそっくりであることがはっきりと分かります。しかし、これでは数が少ないために、この患者様の満足が得られないケースもあり得ます。そこで傾向スコアマッピングはもう一段階詳しい方法があります。それはビジネスの世界ではすでに使われている傾向スコア相別化という方法です。この方法ではそれぞれの群をいくつかのレイヤーに分けます。それぞれのレイヤーは同じような性質を持った対比した人物が選出されています。この技術を用いれば、傾向スコアマッピングの欠点である母集団を削ってしまうという性質が改善されます。しかし、これには AI 人工知能を用いた機械学習により行楽因子を特定していくという重要な問題があります。仮に外来で AI を使って傾向スコア相別化ができたとしますと、この患者と同じグループの女性がこのように3人ずつ選出されました。そうすると、この3人が入院日数がそれぞれバラバラに違いますが、この患者自身はより具体的に自分が手術を受けるべきか受けないべきかというのを選ぶことが容易になってきます。研究という考え方では、傾向スコアマッピング、 傾向スコア相別化、ランダム化比較試験、実験計画といった順に精密な検査がすることができます。しかしながら、実際に多くの研究論文は、傾向スコアマッチングとランダム化試験です。しかし、私どもが提案するのは、ビジネスの世界でもすでに使われている傾向スコア相別化といったものが臨床で有効になってくると思われます。これを実現するには、攻略因子の考え方が必要です。一般にロジスティック解析では、相互の因子のインタラクションがわかりません。そこで、相互の因子のインタラクションがわかるように書いたものをグラフィカルモデルと言います。このモデルは脳モデルという名前が言われています。しかし、医学論文では今必要とはされていません。では、次にレッスン2に行きましょう。それでは、レッスン2として、今回我々が発表した傾向スコアマッチングについて報告いたします。この研究では、比較する対象として、TVT 手術、そして VEL、これが尿失禁の患者にどちらが適切かということを研究していくわけです。それでは最初のスライドを見てください。では、実際の論文ではこのように書きます。多くの場合は、治療法 A と治療法 B を比較するような論文を書きます。しかし、傾向スコアマッピングは普通2群の比較になりますので、コントロールまで入れて3群の比較をすることはなかなか難しいのです。こちらに TVT と VEL とコントロールを3つを3群に分けました。TVT も VEL もコントロールもケーゲル体操はしています。母集団を決めるのに 5% の誤差範囲内でまず設定をしておきます。最初に3群を比較します。クラシカルウォレス検定を用いて3群の中に差があるかどうかだけを検出いたします。3群を比較する場合、ノンパラメトリックの場合は、クラシカルウォレス検定を用いるのが一般的です。そこで母集団を分析すると、3群の中で唯一有意差が出てくるものが矢印のところです。これは現在独身でこれから結婚する可能性のある被験者たちです。そこで2群について比較します。TVT と VL はマンホイットニーの有検定を用います。2群の比較についても、ノンパラメトリックの場合は、マンホイットニーの有検定、またはほぼ同じ検定の方法がウィルコクソンの検定というものがあります。これを母集団にしてみます。すると、先ほどと同じように、独身の女性において TVT と VL は有意差があることがわかります。3群においても2群においても差が生じますので、VL と TVT は独身の女性においては優位に差があるということになりますから、カルテを調べてみます。そうすると、子供を産む可能性のある女性は人工物を入れた手術に大変不安を考えていることがわかります。次に、治療の経過として TVT と VL とコントロールについて1年間の経過を見ます。この時点ではパラメトリックにはなっておりませんので、比較することはできません。TVT と VL がコントロールに比べてとてもよく尿失禁を治していることがわかります。次に OAB-SS を見ます。これは過活動膀胱のアンケートです。これによると、過活動膀胱が唯一治るのは VEL であることがわかります。治療の流れの違いが分かったところで、論文のレフリーから具体的に教えてほしいという指示がありましたので、TVT と VL の OAB-SS について追加のグラフを書いております。OAB-SS の4点5点というのは非常にシビアな切迫性尿失禁を持つわけです。クレッション3番は切迫感、クレッション4番は尿失禁。どちらも VL の場合は改善するのに対して TVT は悪化することがわかります。これは以前、私どもがワールドジャーナルウロロジーに発表したデータとほぼ同じということが言えます。 ここまで調べたことによって、TVT と VEL を経口スコアマッチングによって同じ数にして比較検討をすることをいたします。TVT も VEL も1時間のパッドテストでは改善することが認められます。次に OABS で比較すると明らかに TVT と VEL は有意な差が出てきます。このことにより VEL の特性というのがはっきりと見て取れます。では最後にオズ比の表を作ることによってパワーバランスを調べ、臨床の実際例としての応用を見て終わりにしたいと思います。次にアドバンテージを調べてみます。アドバンテージを調べる方法はこのようにオズ比を計算するのです。オズ比を計算するとこちらのようになります。もっと細かく論文には記載しております。そこで彼女から言われました。私は35歳で一人子供を産んだ。今は新しい結婚相手を探している。そしたらまた子供が産んでみたい。そして彼女は基礎疾患が何もない。BMI も正常である。となると、このデータを入れると、こちらの図のように TVT と VEL のそれぞれのパワーバランスが分かります。この場合は明らかに VEL は TVT を代わりと言ってよろしいと思われます。このように人工知能を使って患者さん一人一人にそのケースに合わせたプレゼンテーションをする。それはこれから新しい医療として使われていくと思われます。今日のまとめです。AI を使ったインフォームドコンセントについてご説明しました。そして多くの患者は全体像を見るということと個人データを見る、その2つを希望されております。そして個人データという点で経口スコアマッチングを用いればレーザー治療というものが TVT に代わりとして使うことが有益であると証明できます。どうもありがとうございます。
Hello, everybody. I would like to thank Fotona for inviting me to the Laser and Health Academy meeting to present our results with intraurethral smooth erbium YAG laser in treatment of female stress urinary incontinence. The intraurethral smooth erbium laser treatments were designed for patients suffering of intrinsic sphincter deficiency and sphincter atrophy contributing to stress urinary incontinence. And up to now, there were 3 studies. 2 were showing efficacy and safety of intraurethral treatment of ISD and stress urinary incontinence, and 1 showed the efficacy in the treatment of urinary symptoms of GSM. We have been using the handpiece since 2018, and we are going to show our experiences in concomitant use of handpiece for urethra as well as gynecological erbium laser. In this study, the patients were older than in our previous studies, and they were about 58 years old. There were 68 of them altogether with a parity of 1.9. In about 42% of cases, urodynamics was done, and majority of them had stress urinary incontinence. All of them had subjectively stress urinary incontinence, and the severity was none in the mild, and there were 47% of the moderate ones, and severe, there were 52.9%, almost 53%. There were also about a third had also cystocele that graded from 1 to 3. Here you can see that the majority of patients were older than 50 years, and before the treatment, women should have had a pap smear that was not older than 1 year, and vaginal smear and urine should have not been older than a week. The treatment consisted of 2 treatments, 1 month apart, with intraurethral handpiece and concomitantly with the classic gynecological erbium smooth treatment. Every patient had a single oral antibiotic treatment of fosfomycin 3 grams at the evening after the treatments, and we did telephone follow-ups after 3 and 12 months after laser treatments. The measuring tools were ICIQ, and patient satisfaction was shown in VS scale, and we followed the adverse effects. And here you can see the results. The average ICIQ score was significantly reduced from 14.3 to 9.4 after 3 months and 9.3 after 12 months. And individually, patients also showed significant improvement at 3 months after the treatment. Although the results at 12 months for some patients were not as good as after 3 months, all of them improved in comparison with how they were at the beginning. And here you can see the large majority of patients with severe stress urinary incontinence moved to moderate stress urinary incontinence group. 40% of patients from moderate group were either completely dry or moved to the mild group, and 60% of patients from the moderate group remained in the moderate group, but their individual ICIQ scores improved. And severe stress urinary incontinence that had 53 patients before the treatment. After the treatment, only 16% of patients were in the severe group, and after 12 months, only 8% of cases. As for moderate stress urinary incontinence, before the treatment, about 47 patients had moderate mode, and after the treatment, 3 months, 64% and 12 months, 72%. And both at 3 and 12 months, around 20% of patients were either completely dry or had mild stress urinary incontinence. Now, if we look at the ISI by Sandvik, at 3 months, severe and very severe cases disappeared, and the majority of patients reached mild grade, whereas after a year, still none of the patients had very severe, and severe had 14%, and we should remember that before the treatment, about 51% had severe. Those were all good results, but because of the slight worsening of objective scores, answers to questions 3 and 4, how often and how much do you leak, there was a significant shift towards higher severity because the patients were not happy with slight deterioration, and they, because it caused bothersome, patients punished it with high scores on question 5, how much does it affect your everyday life? Then we decided to see how actually was the treatment successful, how much did they leak after 12 months and how often. And when we looked into that, the results didn't change much between 3 and 12 months. So the moderate ones were 51 and 46%. Severe ones were 19 and 20%, and very severe were none after 3 and after 12 months. So that shows that clogging was much more objective than the other severity scales. The patient satisfaction subjectively was very high. After 3 months, 7.1. After 12 months was 6.8. And there were non-serious adverse effects. There was transient burning sensation, mild pain and slight discomfort in some of the patients. And all the adverse effects, if we can call them that, after the treatment lasted only up to a week. And there was vaginal discharge and slight spotting in the oldest patients, as well as slight discomfort at only 3 patients. And what is interesting and comforting is that none of the adverse effects were due to the getting into urethra, because what it caused was slight discomfort, and again only in the oldest patients. This study was started by our urologists because they were less afraid to use the intraurethral headpiece. But then when we saw how good it was for the patients, then we all started using it. What we are planning is to have 3 sessions rather than 2 sessions, because some of the studies show that there might be improvement in adding the 3rd session. So in conclusion, majority of our patients significantly improved their stress urinary incontinence stage after 2 sessions of intraurethral treatment, together with the classic erbium YAG gynecological treatment. Patients were very satisfied. The results were lasting at least, as we saw, the 12 months. The adverse effects were mild and transient, and the intraureteral smoother YAG in combination with classic gynecological laser treatment showed to be both effective and safe. Thank you.
Ladies and gentlemen, have a nice day and wish you in good health. I'm Dr. Su from Guangtian General Hospital, Taiwan. Today I would like to present to you erbium laser labioplasty for hypertrophic labiomyola with low wound closure. Labioplasty is one of the most popular female genital cosmetic surgery, and a high level of patient satisfaction rate has been reported, as high as 90% in aesthetic or in functional outcome. The procedure performed under local or general anesthesia, using instrument or surgical technique, like using scalpel, like using electrocautery. All other post-operative wound was reported to be closed with resorbable or non-resorbable suture. Intradermally continuous suturing or simple interrupt suturing has been reported. And many patients may be very unhappy with their wound recovery, especially when their wound look like Michelin appearance. I call it Michelin appearance, like this, the picture I show you. So because post-operative wound suture maybe have unhappy appearance or maybe take a longer time to do the suturing. So we want to know the outcome if we don't do the suture after labioplasty using laser. Erbium laser labioplasty also been reported under local anesthesia, and it showed good outcome and a very high rate of patient satisfaction. The cutting wound was usually closed with reabsorbable suture. So here we report 10 patients of hypertrophic labiomyola undergo laser-assisted labioplasty, general anesthesia, without any post-operative wound closure. Our patient was from October 2019 to July 2020. There are 10 patients. The labiomyola presents a longer length, 4 cm in length from the base to the edge, and less than 0.5 cm in large thickness. There are classification type 3, according to the Felicio classification type 3. The device we use Fotona Smooth. Cutting piece was R11 and LP mode with 10 Hz, 15 Joule per centimeter square, and 2 millimeters spot size. All the patients were under general anesthesia. We placed KD vascular clamp bilaterally along with the cutting edge. Also put 10 cm surgical guards behind the surgical field to prevent tissue injury close to the labiomyola. When the cutting margin removed, vascular clamp was placed for up to 5 minutes to make sure complete hemostasis. All the patient was in recovery room for 30 minutes for observation. Post-operative medication, we give them 1 week. Antibiotic oral, antibiotic local use, the cream. We teach them to use ice packing to ease the pain, to use gauze packing, pressing if they find bleeding at home. It's pressing about 3 minutes, can stop the bleeding. All the patients return for follow-up every week for 1 month, and we find out all the patients would present a good healing at 3 weeks. Picture A shows complete hemostasis after remove the vascular clamp. Picture B shows the good wound healing at the 3rd week. All the patients 10 patient mean age is 33.5 years old, BMI 23.5. Operating time was about 35.7 minutes. Blood loss was minimal, less than 5 cc. Recovery time is 3 weeks. So conclusion is patient with less than 0.5 centimeters thickness of the lamina can undergo urban laser, and we use a vascular clamp along with the cutting margin to minimize the bleeding. The procedure presents a good healing outcome without any surgery. Suturing. Thank you for your attention. Thank you.
Hello everyone, my name is Gisela Campos, I'm a nurse.
Hi, my name is Maria José Monteiro, I'm a gynecologist and obstetrician and we are based in northern Portugal.
Today we want to present you our case entitled Treatment of Dyspareunia Following Childbirth Secondary to Perineal Scar Fibrosis.
And we're going to talk to you about a woman in their 38 years old that presented in our clinic complaining of dyspareunia since her vaginal birth with episiotomy correction. She described her dyspareunia as a superficial dyspareunia with pain that she described as a tearing or splitting sensation. And she referred that intercourse was only possible with topical lidocaine. She was already seen in another clinic and made multiple treatments with ultrasound and with perineal massages, and she did not report any improvement. In the physical examination, we saw a thin band of scar tissue in posterior vaginal fourchette.
For this treatment, we perform a protocol with 2 steps. In the first one, with the parameters that you can see in this presentation, we increase the temperature of perineal skin until 42 Celsius degrees and maintain that temperature for 3 minutes. Then multiple passes of the second steps were made with overlapping of the fractional end pieces with a rotation of 90 degrees compared to the first position. As a result, a break of the thin scar tissue was noted immediately during the treatment, 60% improvement of pain, and a lidocaine-free intercourse was possible for the first time in a year with a single session. 80% improvement was reported 1 month after the second session. The laser treatment was made with good tolerance and no side effects.
Dyspareunia is relatively usual in postpartum, related not only to the decrease in estrogens, especially in breastfeeding women, but also associated with scar tissue formation following lacerations or episiotomy. And it's important for women to be open to discuss this with their doctors, and for us to make a non-judgmental approach and to try to see what's the cause of the dyspareunia in each woman and to offer the best treatment. In this case, the laser was considered a non-invasive, well-tolerated approach and with good results for the women.
Thank you for your attention.
Thank you.
The Laser and Health Academy, LA&HA, is dedicated to the promotion of research, education and publishing in the field of laser medicine. LA&HA, since its inception, has already become a coordinator of the EU Regional Competency Center for Biomechanical Engineering, connecting several industrial and academic research partners. Moreover, LA&HA is also a member and a coordinator of the EU technology platform Fotona 21. Since establishing LA&HA, we have already achieved so much, and in this process accumulated a wealth of knowledge, experience, and created a wide-spanning network connecting educators, researchers, and doctors alike, providing them with a platform for the exchange of knowledge, ideas, and research opportunities. But with all of this, what is the next step? Where are we going? In the last year, I announced to you a new LA&HA experience is about to happen, and I'm very pleased to say that we've been working tirelessly to make this happen. We've taken the best of what LA&HA was and built upon this excellent foundation to create an even better experience. LA&HA Academy, research, education, library, and publishing represent all of the key elements that are further improved to offer a unique solution and these segments intertwined between each other fully represent the vast scope of LAHA operations. And I'm going to show you a bit of sneak preview into the new LAHA webpage that will showcase our progress. As an integral part, LAHA Academy, with its affiliations to several academic institutions, has state-of-the-art facilities and countless world-class lecturers, is expanding through a network of LAHA centers globally to offer the new and exciting opportunities. LAHA Academy is the backbone of our development, and in the new LAHA webpage, our world-class lecturers specifically will get their own profile page, and you will be able to connect with them and their work more easily. The research subsection will showcase new and exciting research opportunities, projects, and groups with new researcher recruitment readily available. We're also expanding on our educational program with a variety of courses ranging from online training courses, workshops, and the LAHA Master Program that is available already today. We are expanding also a new fellowship program that will engage a broader field of participants and enhance their knowledge on a selected field. The foundation of our knowledge is, of course, our comprehensive library that is constantly growing and has already become the ideal resource for evidence-based content, be it in the form of video lectures, journal entries, or clinical notes or articles. Most importantly, a universal search through our entire categorized library will be available by a click of a button. As an extra feature, this search function will also be available in your local language to facilitate an easier and more fluent search experience. And lastly, LAHA is also a publishing organization with our own international peer-reviewed journal that we are making even more accessible to potential researchers and offer to them a platform for new and exciting opportunities. With our overview on our publishing activities, readily available publication submissions, we are further improving on our already internationally accepted peer-reviewed journal. And lastly, when first asked where we are going, well, the answer is simple. We are going to create an even better global network for quality education, research, and publishing for the promotion of evidence-based laser and energy-based medicine. For now, thank you for your attention.
So, dear guests, dear friends, dear LAHA community, thank you for being with us. We hope you enjoyed our symposium. If you have any questions, comments, anything you would like to share with us, please send them to info@laserandhealth.com.
We can't wait to see you next year, but this time in person. See you next year. Bye.
See you next year.